Welcome to the 14th edition of Kerala Society of Ophthalmic Surgeons CME series. Actually, this is the third this year. The first one we did with Alapi. The second we did with Kozhikode, and this is the third one this year after Dr. Shashikumar has taken over as the president of Kerala Society of Ophthalmic Surgeons. I'm Dr. Srini Adaklon, chairman of Scientific Committee of Kerala Society of Ophthalmic Surgeons. KSOS has been doing a lot of scientific activities for the past one and a half years. And all these activities have been very popular and have been very successful. If you take the two CMEs that we did this year, the first one that we did with Alapi was on the training opportunities that are available on cataract surgery, SICS and FACO, and different institutions across India. So we about 25 institutions participated, and that was an extremely popular one, and combined viewership would have crossed about 7,000. So even the one on oculoplasty done with Kozhikode, it's nearing 1,400 viewership, which is very good for any scientific activities these days. So this program, we are doing it as a part of the World Glaucoma Week observations by Kerala Society of Ophthalmic Surgeons. We are starting off with this, and then we're going to have a camp on May 15th, where the free glaucoma screening camp is going to be conducted in hospitals across Kerala. Last year, we did the same thing. We had about 130 hospitals participating, and this year we are expecting more than 150 at least. So we're doing newer ways to get to people and spread the message about the problems with glaucoma and all. So here today we have eminent faculty from across India and from our own state speaking on different aspects of glaucoma. Dr. Shweta is an organizing secretary. She has done a lot of work on this. I'm sure this program is going to be quite successful, and we are lucky to have Dr. Thomas Terian, the president-elect of Kerala Society of Ophthalmic Surgeons. He'll be inaugurating this program, and Dr. Simi Manoj Kumar, who is the president of Ophthalmic Society of Kannur, will be presiding. I request Dr. Simi to take over and carry the proceedings further. Dr. Simi, please.
Hi. Am I audible?
Yeah.
Yes.
Am I audible?
Yes.
Okay. A very warm good evening to all. Yeah. A very warm good evening to all. We at the Ophthalmic Society of Kannur, we feel very extremely privileged and honored to have been entrusted with this in the 14th module of CME series under the aegis of KSOS from till March 18th. So we have selected a topic, Glaucoma Demystified, and our organizing secretary, Dr. Sweta, has gone into real hard work in getting eminent faculties and panelists for the session. Of course, with the help of our scientific committee chairman, Dr. Srini Adaklon. So I welcome all the eminent faculty and the panelists and the viewers to this CME, and I'm sure this is going to be a very fruitful session, and there will be many take-home messages for the CME. Thank you.
Thank you, madam. We'll now share the virtual lamp lighting slide. I now request our President-elect, Dr. Thomas Cherian, sir, to deliver his inaugural address. Excuse me, sir, you are not audible.
Am I audible now?
Yes, sir. Yes, sir.
Good evening. Honorable President of OSK and my dear friend Dr. CME Manoj Kumar, Secretary Dr. Seema, Organizing Secretary Dr. Shweta, KSOS Scientific Committee Chairman Srini, and distinguished faculty from across India. It is indeed heartening to note that the Ophthalmic Society of Kannur is organizing this webinar on glaucoma during this World Glaucoma Week. And we have a galaxy of experts in glaucoma today to share their knowledge and grace this occasion. OSK and the ophthalmologists of Kannur are doing an excellent work, and indeed the KSOS is proud of this district ophthalmic society. And we have been going through some good work, a good series of CME, and Dr. Srini has to be given due credit for all this. The KSOS plans to take this forward during this year. Today, I am sure all of us will be enriched with the knowledge shared by our faculty. I wish the CME all success, and I declare this CME open. Thank you.
Thank you, sir. Good evening, one and all. Ophthalmic Society of Kannur is indeed privileged to conduct the 14th module of KSOS CME series on glaucoma on this World Glaucoma Day. First and foremost, let me express our immense gratitude to our scientific committee chairman, Dr. Srini Edaklon, who helped us behind framing the CME within a short span of time and in gathering eminent speakers from all over the country. Next, let me thank our beloved Dr. Thomas Cherian, sir, President-elect KSOS, who came in last minute and helped and inaugurated our CME. Let me also thank all the eminent speakers. We have a galaxy of speakers from various parts of the country in all the sessions who cooperated with us and agreed to join us today to deliver valuable information on glaucoma. Thank you all. And let me also thank our organizing secretary, Dr. Shweta, who worked very hard behind framing this CME in a short span of time, and also our president, Dr. CME Manoj Kumar, and all other members of Ophthalmic Society of Kannur, who help us with all the programs being organized. Thank you all once again, and we can move on to the first session.
Thank you so much, ma'am. Good evening, everyone. Thank you for joining us today with this on this World Glaucoma Week. We have planned this session, the 14th episode of KSOS CME series, entirely on glaucoma. So this session is going to be extended for 3 hours. Each session has 3 talks, which will be for 10 to 15 minutes, followed by a 20 minutes panel discussion. We have distinguished speakers speaking on the matter. The attendees can ask the questions in the YouTube link, which we will be addressing here. Now, these are the talks that is going to be conducted. Now, first session is on glaucoma clinical trials and research. And the chairperson for the first session is Dr. Meena Madam, who is a senior consultant in glaucoma at Chaitanya Eye Hospital and Research Institute, Trivandrum. With Madam, we have 3 panelists, Dr. Nimita Najib, Comtrust Eye Hospital, Calicut, Dr. Srini Edaklong, who is the chairman KSOS Scientific Committee, is from Comtrust Hospital, Talasheri, and Dr. Smita VK, who is from Little Flower Hospital, Angamali. And with us, we have 3 speakers. First will be by Dr. Bhaskaran Mani, sir, who is a Deputy Director, Glaucoma Services and Research, Vision Research Foundation, Shankara Netralaya, Chennai. He has more than 250 international publications, 8 book chapters, and 8 co-patents in the field of glaucoma, and he's very much involved in academic research. We welcome you, sir. I am going to introduce all 3 speakers so that I do not take much of a time, and then I'll give out the session to the chairperson to moderate. The second talk is by Dr. Kamala ma'am, who is a consultant glaucoma and DNB teacher at Shankara Eye Hospital, Shimoga. She did her fellowship from Shankara Eye Center, Coimbatore, and she has presented papers in several CMEs, national and international conferences. Third speaker is Dr. John Davis Akara, who is an alumni of JIPMO Pondicherry. He did his glaucoma fellowship from Aravind Pondicherry and cataract from Shankara Netralaya. He has won various awards in national and international conferences, and he is a young innovator. And I also welcome Dr. John. Now I invite Dr. Meena ma'am to chair the session and moderate the session. Over to you, ma'am.
Can you hear me?
Yes, ma'am, we can hear you.
Yes, ma'am.
At the onset, I wish to thank our KSOS and especially Dr. Srini and Dr. Shweta and the Kannur Ophthalmic Society to have given me this opportunity to moderate this session on clinical trials and research as the chairperson. And we have distinguished speakers with us who have already been introduced by Dr. Shweta. So I go to the first talk of the session by Dr. Bhaskaran Mani. Over to you, sir.
Thank you, ma'am. I'd like to thank KSOS for giving me this opportunity, and also Dr. Srini especially, and Dr. Shweta for the coordination. Is the screen visible?
Yes, it is.
Yes. So the first topic is an update of glaucoma trials. I'll be sharing the glaucoma trials with Dr. Kamala, who will be doing some of the older clinical trials and some portions of it which are like the continuations of the older trials. So I'll be concentrating more on the laser trials in both open angles and the narrow angles, and subsequently on advanced glaucoma primary track study. So no financial interest. So the first study is on the laser trial. It's probably an underutilized treatment modality. We usually have this laser trabeculoplasty as a second line of treatment after the medications in the European Glaucoma Society guidelines and the Asia Pacific guidelines as well, and the World Glaucoma guidelines. But the question the researchers asked was, does primary SLT improve quality of life versus the eye drops? And it's an observer masked RCT, treatment naive POAG or OHT patients were included. SLT was compared to IOP lowering medications in the other arm. The primary outcome was health related quality of life at 3 years, and that's what they were looking for with the EQ5D tool. And cost effectiveness, clinical effectiveness, and safety were secondary outcomes. Now, among the allocated patients, 329 in the SLT arm and 323 in the medications arm were analyzed. And no surprise there, HRQOL at 3 months was similar between the two groups at 36 months. And but the intraocular pressure was under control without any drops among 74% of these SLT patients at 36 months. And that is something which is important for NHS, which was conducting the study, because of the costs involved in treatment of glaucoma. And the other outcomes, such as the visual acuity, intraocular pressure, visual field MD, and the quality adjusted life years were similar, while the cost, average cost per patient for all the ophthalmology, something again of significance. So, of course, this may be relevant to our population as well, and that's something which we need. In terms of disease progression, was trying to be a bit inclined towards this SLT group, 3.5% versus 5.8% in the medication group. Lasers in glaucoma and ocular, the 6-year results also confirmed this disease progression issue, the time to disease progression, time to glaucoma surgery, and also time to phacoemulsification were all longer in the SLT group, as you can see with the Kaplan-Meier graphs here. And the second part of this program was doing a repeat selective laser trabeculoplasty, and they selected 25% of these patients who required the repeat SLT according to treatment escalation at 18 months, and 115 of them were selected to have uniform follow-up. And it is also good to know that 67% of these eyes remained medication naive at 18 months. So this is kind of like a synopsis of the various light trial papers that were released. So at 36 months, 74% of them remained drop-free, and the cost for SLT was lower. And repeat laser done at 18 months gave 67% drop-free at 18 months. And at 6 years, 70% remained drop-free and with less progression in the SLT group for both trabeculectomies and the amount of cataract extractions that are needed. So this is a smaller study which was of interest, SALT, that is steroids after laser trabeculoplasty. So it had 3 arms, 96 eyes, a smaller study, NSAIDs versus steroids versus placebo at 12 weeks. And they found that the NSAIDs group and steroids group did better than the placebo group. And that's why we keep using the NSAIDs, non-steroidal anti-inflammatory drugs 3 times a day for 5 days, which was the regimen used in that study. So that is about the laser trials in the open angle glaucomas. The demerits I'm not going into because of time factor. Now the laser trials in the narrow angle group, the primary angle closure suspects, ZAP and the ANALYSIS is what I would like to discuss. And the ANALYSIS is a trial which I was involved from the beginning till end. And this is a patient with the primary angle closure suspect asymptomatic. As you can see, the angle closed. How will you manage this patient? She is around 61. And so we are worried about her developing angle closure. We have various options here. Pilocarpine, older one, we may not be using it. Phaco, of course, depending upon the risk factors, we may not consider. So laser PI and observation are the 2 options. And laser PI has its pluses. It can prevent progression, but also can cause other issues and the cost factor involved in treating all the patients. So this study was done to look at the efficacy of LPI and the progression over 5 to 6 years. And these 2 trials have been, in fact, the Singapore ANALYSIS trial started earlier, but the ZAP trial finished first and published first. So it's an RCT, and bilateral asymptomatic narrow angle subjects were included, more than 50 years of age. This is something which you need to note, asymptomatic. If it's the patient is symptomatic, you go straight away to an LPI. One eye underwent LPI and the other underwent no treatment, and they followed up with these patients for 5 to 6 years. And 900 patients were included in the Chinese arm, that is the ZAP trial, and in Singapore was 480 patients. These were 2 independent trials going parallelly relatively. And the primary outcome measure was incidence, cumulative incidence of primary angle closure and primary angle closure glaucoma, and also looking at the incidence of APAC in those who did not undergo the LPI. And there were some secondary outcome measures in the ANALYSIS trial as well. There were some basic differences in terms of inclusion. The ZAP trial did a darkroom provocation test and removed certain patients, and they did not include diabetic patients. But the ANALYSIS trial did not do a provocation test, but it used a Diamox after dilation, 1 Diamox after dilation, and also they removed patients who had more than 25 millimeters of mercury after dilation, as well as more than 8 millimeters of mercury spike in IOP. So these are some of the things which we need to consider when we are thinking about observing these patients. Another difference is that the ZAP patients were community-based patients, while the ANALYSIS patients were hospital-based and a mixed group. The ZAP patients, being community-based, had a wider angle width, and there are slightly different ethnicity. Chinese, Guangzhou is more northern, and Singapore Chinese are more southern Chinese. So they had some differences as well. And you know that Singapore reported the maximum acute angle closure eyes. So these are some things which we have to consider when we are looking at our population by itself. And the percentage progression cumulative incidence, where the ratios were similar. The LPI groups had lesser progression and lesser cumulative incidence. But as you can see that the overall percentage of progression happened in only 10% patients in both the groups, both the follow-up as well as the LPI group. But 90% did not progress. And majority who progressed had only PAC with some PAS. And you can see the hazard ratio basically was protective for LPI around 50%. And it was similar in both the studies. And the number of acute primary angle closures were slightly more in the Singapore group compared to the Chinese group. Of course, these were very, very rare, some very like 3 to 6 out of 1,000 patients, 10,000 patients actually. So now the risk factors of progression were not seen much in the ZAP trial because they did not include diabetic patients and other things. And we could identify narrower angles at baseline, higher baseline IOP, higher post-dilation IOP, diabetes mellitus, and age and male gender as risk factors for progression in the analyst trial group. Those are things, again, you need to consider. And if you look at the recommendations, patients can be observed with no LPI because the number of people who progress were low without LPI. And the NNT, there is number ready to treat in analysis, was 20.7. That means you have to do 21 patients LPI before one patient did not progress after 1 year. So this favored select patients LPI only. And unfortunately, the risk factors identified were less. And we need to have more such studies to find out more risk factors as well. And some of the patients who are not included in the trial are higher cup disc ratio, post-dilation IOP more than 25 and more than 8 from baseline, diabetics that is not included in ZAP trial, and family history of glaucoma. These are patients who we may need to consider LPI in the first go itself, or depending upon other risk factors as well. So now these patients, when they had a cataract, what do we do? So this is the EAGLE study. It's a bit controversial study. They looked at the quality of life and they used certain terminology which is away from its original protocol. We were part of the study when I was in Singapore, and we didn't opt out of the authorship because of some issues with the panel discussion at the end, because they used the term early lens extraction when we objected to it. It was early cataract extraction. These patients had a vision more than 612 and they were not symptomatic visually. So, but then when they started using the term early lens extraction, it gave a wrong meaning. So it was objected to, but finally the panel decided to include that. And it was a study looking at more than 50 years of age at 36 months for early cataract extraction versus LPI in primary angle closures and primary angle closure glaucomas. And the QOL was better due to the visual acuity improvement after the cataract extraction, obviously. And the cost effectiveness was worse for cataract extraction, and advanced glaucomas were excluded. These are something which we have to look at. More than 200 patients were included in the two groups. Intention to treat analysis, and obviously the intraocular pressure was slightly better in the cataract extraction group. That's what we see in subsequent various studies as well. Even though the number of procedures that are required after LPI was slightly more, the numbers were very small, so it was not significant between the two. And as you can see, that the flaw in this study was that gonioscopy was not done or missing in many patients. So after the follow-up, during the follow-up, the initial time they had, of course. And one of the things which we have to look at is the number of complications that are noted here in the clear lens extraction group, even though some similar complications were noted in the laser peripheral aberration. So basically you are looking at some malignant glaucoma, macular edema, macular hole, and PC rents. And these are with experienced cataract and glaucoma surgeons are excluding difficult cases. That's something which the authors themselves agree. If inexperienced surgeons do the surgeries, they could have increased rates. So that is something which we have to think about when we are looking at the EAGLE study results. So the surgery cataract extraction should not be taken lightly. Now the next study is the TACS, that is primary trabeculectomy in advanced glaucoma. A short run through this. Primary trabeculectomy was done in patients with advanced glaucoma versus primary medications, and they were followed up for 2 years. And the second paper published the visual field outcomes as well. So this study was mainly the primary outcome was QOL, and there was no difference between the two at 2 years. And 2 years is relatively a short period for surgery follow-up, if I may say. And the intraocular pressure obviously was slightly lesser than the medication group in the trabeculectomy throughout, as you all can assume. And the tendency in the surgical arm for less progression was seen with the visual fields as well. But at 2 years, the rate of progression was not significant. But you can see in these curves, it's kind of tending to flatten out in the trab arm, but the medication arm is going up. And they used a certain clustering method and all, which has some flaws, but long-term follow-up is definitely needed in this kind of studies. So finally, the take-home message is light and salt trials. It seems that it is good to do primary SLT, even repeat SLT in these patients, and better to use NSAIDs. That's the take-home message from those studies. ZAP and analyst trials, LPI need not be done in all the patients since 90% do not progress, especially the asymptomatic PACS group. However, when we do the LPI in some patients, it reduces the risk by 50%. Eagle trial, cataract extraction by experienced surgeons can be considered in select PAC patients, needs longer follow-up. Advanced glaucomas, doing primary trabeculectomy probably seems to lower the intraocular pressure better at 2 years, but long follow-up is needed. And I think those are the recent trials updates, and there are more trials that are there in terms of surgical and other things which we will not go into. And I would like to acknowledge some of my co-authors in some of these trials. Thank you very much for your attention.
Thank you. Thank you very much, Dr. Bhaskaran, for the excellent elaboration of all the laser trials as well as the tags. And I think I'm instructed to go for discussion along with the panel. So I think I would move on to the next talk in the session. And I invite Dr. Kamla S. for the talk. Over to you, ma'am.
Hello. Yeah. Can you hear me?
Yeah, you're audible.
Yeah.
Share
So
screen.
I'll be just sharing. Yeah, I'll just share this. Yeah. Is it my screen is visible?
No, it's not visible as yet.
Okay. Now?
No, ma'am, not yet.
Okay. And to me, I think it started in the slideshow.
You may want to cut the video and try the sharing, and maybe there is some issue with your streaming.
1 second. Oh, it's not.
Not yet, ma'am. It's not yet come on screen.
Ma'am, try cutting the video. Stop the video and try sharing, because I think there is some streaming issue.
You can stop share screen, try again also.
Do we need to go to the next speaker and come back, or?
Now is it visible, ma'am?
Yes, it is, ma'am. Please continue.
Yeah. Okay. Just a second. There's some.
Make it full screen.
Yeah. Yeah. Good to go, ma'am?
Yeah, you can start.
Yeah. So I'll be talking on how to put the glaucoma glaucoma trials and clinical practice. So whenever we see a patient, we are always confused whether to treat or observe, whether to start medication or surgery, or if surgery, then which one, and should we consider laser treatment. So I think the laser treatment part of it, Dr. Bhaskar has clarified the thing. So I will like to take up on the next few trials which have happened in the history of glaucoma treatment. So the trials can be divided into treatment versus no treatment. And there is a big array of trials which are there. And as compared to treatment versus treatment, we have even more trials which are there in that. So certain important trials I'll be handling now. So first one is the ocular hypertension treatment study. So the first 13 years, that is the phase 1 and phase 2 of the study, they included about 1636 participants, and the inclusion criteria was 40 to 80 years, untreated IOP of 24 to 32 millimeters, and gonioscopically normal open angles and normal optic disc. And the target IOP was supposed to decrease from 20% from the baseline. So the endpoint was the cumulative proportion of participants who developed open angle glaucoma. So at 13 years of follow-up, around 4.4 in the medication group and 9.5% patient in the observation group converted to glaucoma. So the early conclusions, that is after the 13-year study, they concluded that early treatment of raised IOP in OHTS reduces the risk of conversion to POAG, particularly in patients with risk factors at baseline, that is the older age, higher IOP, thinner corneal thickness, larger cup to disc ratio, and higher visual pattern standard deviation. The phase 3 trial, which was conducted from 2015 to 2020, all living patients were re-examined for the original OHTS cohort, and the ultimate objective of asserting effects of treating elevated IOP and early POAG, as well as long-term vision loss and quality of life, they continued in OHTS 3. So specifically, it was conducted to determine the 20-year incidence of POAG and construct a 20-year model for stratifying the POAG risk. So what happened in OHTS 3 was all living patients were re-examined, and the incidence of POAG was 31.7% in the participants stratified as low risk and in the baseline model, and 47.6% in the medium risk and 59.8% at the high risk model. So the study backs up that the model devised by the OHTS researchers to categorize patients into risk groups and encourages close monitoring and concentration of treatment in high risk patients. So the lessons which are learned in OHTS is take the risk categories into account, and the consider observations before treatment in some patients, because only about 10 to 20% patients they progress from OHT to POAG. So 80% of patients, you're actually treating them unnecessarily, and the side effects of the drugs without any actually major benefit is there. And glaucoma is also a slow visual loss. So probably we really don't need to jump into action immediately, but we have to take the risk categories into account. And if we are waiting for a longer time, probably there could be new drops in the armamentarium. And the patients with CCT less than 555 are 3 times at higher risk. And the ocular hypertension patient at high risk may benefit from close follow-up and from early treatment, whereas low-risk patients who can have less follow-up and may not need very early treatment. And it also depends upon the individual factors such as age, health status, life expectancy, and patient preference. Coming to the EMGT. So in this, what they were looking at is that the intraocular pressure was reduced to 25% in treated cases. 255 patients with early diagnosis were included in the study. And the treatment was that trabeculoplasty and topical hypotensive medications were administered to 120 patients, and no treatment was 126 controls. So what they found in the study was the risk of progression decreased 10%, and the control group remained unchanged at 3 months. IOP of the treated group was reduced by 25% throughout the follow-up period, and the medical treatment of POAG reduced the risk of progression by 27%. So each 1 mm drop from baseline, the risk of progression lowered by 10%. So what the lessons we learned from EMGT was that it gave the most solid proof that pressure lowering is beneficial in glaucoma treatment in all clinical situations. And every 1 millimeters of IOP reduction was associated with a risk reduction of 10 to 13%. And the rate of glaucoma progression is variable, difficult to predict, even in those who are being treated. And EMGT found that IOP fluctuation is not a risk factor, whereas mean IOP was taken into account. And certain additional protocols which came up was that the testing the visual fields every 3 to 4 months, beginning at the diagnosis. And after 2 years, we need to take a closer look to see if the target IOP needs to be reset. And we have to be persistent in eking out that extra millimeter mercury reduction. And EMGT researchers also found that exfoliation syndrome is an important pressure-independent risk factor for progression. And aggressive treatment, if it is a pseudo-exfoliation, bilateral disease, older patient, higher IOP, worse mean deviation, and presence of disc hemorrhages. Coming to the next study, that is the normal tension glaucoma study, the collaborative normal tension glaucoma study. So the study included population age 20 to 90 with normal tension glaucoma. Intervention led to 30% IOP reduction via either drops, laser, or surgery. And in the controls, no treatment were given, and outcome was the progression of disease. So the key finding was 30% IOP reduction which was expected with the medication. So in the Kaplan-Meier's, this thing, if you can see here, it's very small print, but 80% survival in treated arm versus 60% in untreated arm is what the study tells us. And the conclusion was that reducing IOP by 30% significantly reduces the progression of visual fields in the normal tension glaucoma. And this benefit is seen only if cataracts are not caused by the intervention. And lowering IOP without producing cataracts is much more beneficial. So of the 34 cataracts which developed during the study, 11 occurred in the control group and 23 in the treated group, in which the highest incidence was in the patients who underwent filtration surgery. Due to the influence of cataract on visual field analysis, the authors could only conclude that therapy that is effective in lowering IOP and free of adverse side effects would be expected to be beneficial in the patients who are at high risk of disease progression. The lessons learned here was the level of pressure influences the course of NTG, as evidenced by the slower rate of incident visual loss in cases with 30% or more lowering of the intraocular pressure. The rate of progression without treatment is highly variable, but slow enough that half the patients have no progression in 5 years. Faster rate occurs in women, in patients with migraine headaches, and in the presence of disc hemorrhages. Beneficial effect of IOP reduction on progression of visual change in NTG was only found when the impact of cataracts on the visual field progression, produced largely by surgery, was removed. And not all untreated patients progress. The natural history of NTG must be considered before embarking on the IOP reduction with therapy, especially in a NTG. And surgery increases the chances of cataract. Probably it is best reserved for patients with severe visual loss. So coming to the next next study. Am I audible yet still?
Yes, you're perfectly audible.
Yeah, I think there's some hits going on here. 1 second. So the CIGTS study is a multi-center study which included 14 clinical centers, 578 subjects with primary open-angle glaucoma and pigmentary glaucoma were included. And the patients were randomized to medication and trabeculectomy. And the follow-up visits were through 9 years. And in between, if required, the patient received ALT. So the outcome here was that the early surgical intervention in patients with POAG reduced visual field progression at 6 years, and patients with more advanced baseline visual field loss, older age, and non-white patients and diabetics were more likely to progress. So in the medication group, actually 51% of the patients who were there, they were given stepped medication to reduce the IOP and bring it to the target IOP. So the CIGTS, what the lessons we learned was that we need to discuss the fear of blindness with the patient and consider surgery first in patients with moderate or advanced disease, especially in those with a mean deviation of minus 10 decibels or worse. Remember exceptions that diabetics don't do well with initial surgery, and surgery is easier before eye drops are used. That is, pristine conjunctiva yields better surgical results, and keep IOP steady. Initial surgery tends to protect against the IOP spikes, and the drops don't take care of these fluctuations. And the initial complications with surgery are there, but they resolve without sequelae. And the risk of endophthalmitis is less than 2% over 7 years. The AGIS, again, it had two groups, 332 black patients and 249 white patients. And the patients who were included were the advanced POAG, IOP more than 18 with confirmed optic disc or visual field deterioration, and no previous invasive laser or ocular surgery. Follow-up 6 monthly for it went on for 7 years. And what was concluded was that the outcomes were different depending upon whether the patients were African American or Caucasians. And the analysis of a sustained decrease in visual acuity showed that Caucasians did slightly worse and African Americans did markedly worse. It dependent upon how the randomization took place. So whether they received trabeculectomy, argon laser trabeculoplasty, and then repeat trabeculectomy, or the second arm. And according to the visual field outcomes, Caucasians assigned to the ATT group fared better, while a worse outcome was again demonstrated for the African Americans. So in AGIS, take race into account while when you're choosing the therapy, and the African Americans should have laser first and Caucasians should have trabeculectomy first. So coming to the surgical one, that is the TVT, that is tube versus trap. So the inclusion criteria in this was 18 to 85 years in inadequately controlled glaucoma on maximum tolerated medical therapy. And they had a previous trabeculectomy and or cataract extraction with intraocular lens implantation. And they did have a lot of exclusion criteria. And the method was the multi-center RCT trial with 17 centers which were included. And the interventions were the bowel glaucoma implant or trabeculectomy with mitomycin C. Here they use 0.4 milligrams per ml. And main outcome measures were IOP, visual acuity, and the reoperation for glaucoma. So 107 in the tube group and 105 in trabeculectomy group, they were followed up. And these are the 5-year follow-up results. Where the cumulative proportion of the surgery failing was seen more in trabeculectomy group than in the tube group. So the lessons learned here was we should put tubes in our armamentarium, and TVT makes clinical more comfortable in placing drainage shunts in cases where previously a trap would have been the first approach, and assess patients' unique needs. Factors such as tolerance of medical therapy or willingness to undergo repeat glaucoma surgery if needed must be considered when choosing between the two procedures. And tube shunt surgery had a higher long-term success rate. In addition, shunts had a lower rate of post-operative complications and reoperation of glaucoma, whereas trabeculectomy plus mitomycin achieved better early pressure control in the first 3 months and less use of adjunctive medical therapy in the first 2 years only. So coming to the primary tube versus trabeculectomy, this was almost like the previous study. However, here in this study, they use the pristine conjunctiva. So in the previous study, the patients had undergone cataract surgery. Here, this was primary treatment. So again, 242 patients were enrolled for the study. 125 patients, they were enrolled for tube shunt without MMC, and 117 patients where mitomycin 0.4 milligrams per ml for 2 minutes was used. So the primary outcome was the cumulative probability of failure. In tube shunt without MMC, 17.3% failed, and trabeculectomy with MMC, 7.9% failed. So the lessons learned were the outcomes were at 5-year follow-up. The mean IOP was similar for both the groups, and the procedures, almost same amount of IOP reduction. The cumulative probability of failure was not significantly different between the tube and trabeculectomy cohorts. With regard to need for supplemental medications, the rate of complete success without additional medications was higher in trabeculectomy group than for the ones who received the shunt. Also, at 1-year follow-up, the surgical failure rate was significantly higher in the tube group than in those who underwent trabeculectomy. But the end of 5 years, the difference was no longer statistically significant. And the risk factor analysis found that lower postoperative IOP to be significantly associated with failure. Specifically, the rate of tube shunt failure was strongly influenced by lower preoperative IOP. And while both the procedures are viable surgical options for managing refractory glaucoma, the findings suggest that TRAB with MMC is preferred surgical procedure in the subgroup of patients who either are non-adherent or poorly tolerant to glaucoma therapy. And surgical skill and experience with each operation are important, and additional considerations that were not properly evaluated in this study. The next study is the ABC or ABB trial. That is the Ahmed and Bawel comparison trial, where the patients were randomized into 143 and 133 groups respectively. And the follow-up at 1 year shows that both are almost same. The IOP reduction with both are almost same. And the at 60 months follow-up, again, the IOP reduction seems to be almost the same. But cumulative glaucoma reoperation rates are look to be more with the Ahmed implant. So the lessons learned here are similar rates of surgical rate success were observed in both the implant and at 5 years. And the Barbell gave a greater IOP reduction and lower rate of glaucoma reoperation than the AGV. Failure of AGV was usually due to the high IOP endpoints, and the failure with BGI was mostly commonly related to safety endpoints like the hypotony, implant explantation, and loss of light perception. Additional approximately 2 millimeters mercury lower IOP obtained with the BGI must be weighed against the larger number of safety endpoints in the BGI group compared to the AGV group. So in conclusion, the present clinical glaucoma practice, the guidelines have very, very strong evidences and for efficient patient care. IOP is the main risk factors in all type of glaucomas, and identification of risk factors, degree of disease, and the quality of life is the key. Customized treatment follow-ups and interventions according to the need of the patient, and look for rate of progression, reset target IOP whenever it is needed. Thank you.
Thank you, Dr. Kamala, for the excellent presentation and compilation of such a vast topic into such a short duration.
Yeah,
we move on.
Time was too short.
Yeah, we move on to the next talk. I'll discuss with you along with the panelists. And I move on to the third speaker of the session, Dr. John Day. Over to you, Dr. John.
Thank you, ma'am. I'll be talking about the future of glaucoma treatment. Am I audible, ma'am?
No, I think the screen, Dr. Kamala, you have to stop sharing your screen.
Right. I'm still unable to share. I think Dr. Kamala is still sharing her screen. Yes.
Yes.
Now I have the option. Yes.
Yeah, now share your screen.
Okay. So wishing everyone glaucoma week. Is my screen visible?
Yes.
Okay, ma'am. So I'll be talking about the future of glaucoma treatment beyond intraocular pressure. We have been taught since early days that glaucoma is a a chronic progressive optic neuropathy where intraocular pressure is the only modifiable risk factor. But that is no longer the case. We have slowly started unraveling this complex disease called glaucoma, and we have been looking at other modifiable risk factors. And some of the known modifiable risk factors which we knew for a long time are these. That is the socioeconomic status, the nutritional intake, the body mass index, exercise, smoking, sleep apnea, all these things. And these are things which we often ignore. In fact, we tell the patient the treatment as medication, laser, and surgery, and forget to take care of these things. So we should be aware of these so that our patients know what to do. And in addition, it has been shown that vitamin A, B2, and E have a reduced risk of glaucoma. Overconsumption of vitamin C has an increased risk of glaucoma. Safflower oil again reduces the risk of reduces the intraocular pressure. Obesity, among several other diseases, increases the risk of glaucoma as well. But BMI by itself is not conclusively shown that there is a direct relationship between increased BMI or decreased BMI and glaucoma. Exercise reduces intraocular pressure, but it has been shown that if the person stops exercising within 3 weeks, it comes back to the baseline intraocular pressure. Smoking, even though it has been shown to have several damaging effects, it has not been shown to have a direct correlation to glaucoma. It definitely affects the eye. So even though not glaucoma, it is associated with ARMD. Sleep apnea is a definite increased risk of glaucoma. So all these are risk factors which we are already looking at, which we often forget to advise our patients. And of course, the non-modifiable risk factors cannot be changed: age, race, and gender. These are things which are non-modifiable, of course. Patients and, of course, the media often projects the use of medical marijuana for glaucoma, but we should be aware of what is shown in the media and answer the patient's queries if they do have queries. So definitely cannabinoids lower the intraocular pressure and also offer some neuroprotection. Studies have shown that it increases the optic nerve head blood flow, and tetrahydrocannabinide increases the retinal ganglion cell survival in animal model. All these are known facts, but oral administration is not suitable because of side effects, variable absorption, and poor predictability. That is the most common reason why patients in some places might ask about this. And topical cannabinoids, even though they lower the intraocular pressure by 30%, it lasts only for 6 hours, and that is not even comparable to our conventional treatments. And of course, there is tachyphylaxis also in addition to this. And we know that ocular blood flow and ocular perfusion pressure are important factors which affect the optic nerve. For normal tension glaucoma, these are very, very important. But even for primary open angle glaucoma with increased pressure, these also have to be looked at. So the mean ocular perfusion pressure will be calculated thus: 2/3 of diastolic blood pressure minus 1/3 of systolic minus diastolic, that range, and subtract the intraocular pressure. So this perfusion pressure between the blood and the intraocular pressure is what we look at. And OCT angiography helps us look at the optic nerve head and its perfusion. And this may not be of clinical use right now, but it will definitely be useful in the near future. So the main treatment point from this is to ensure the optimal BP control so that it is not too low of an ocular perfusion pressure, because sometimes hypertensive patients may be taking too high of a medication, and that might affect the optic nerve. Of course, neuroprotection is what we think about when we talk about non-IOP related things. And there are several neuroprotective agents which have been theorized, tested. Some have failed, some have worked. And of course, glutamate and nitric oxide pathways, deprivation of the internal tropic factors, loss of intracellular self-repair processes, and generation of intracellular destructive processes are the four main types of optic nerve damage that is seen. And so if we look at the classification of the treatments for neuroprotection, one would be excitotoxicity related, which would be glutamate and memantine as a treatment, oxidative stress and mitochondrial dysfunction, autoimmunity, glial cell modulation, stem cell therapy, and gene therapy. So excitotoxicity, we had memantine, which is used for Alzheimer's disease. And even though theoretically it was very promising, but clinical trials did not show adequate results. But there might be something in it which we have been missing. Oxidative stress can be reduced by flavonoids and other treatments. So ginkgo biloba is one medication which has been shown to work and reducing the visual field progression in normal tension glaucoma patients. And so that increases the ocular blood flow. Mitochondrial dysfunction, coenzyme Q seems to be promising, but no human trials yet. And protein misfolding is theorized as a cause for glaucomas. So just like Alzheimer's disease, it might be protein misfolding which might be causing some forms of glaucoma. So heat shock protein inducer, geranyl geralastone, it's shown to reduce the retinal ganglion cell death. And of course, stem cell therapy is also in the early stages. There have been some very, very expensive but successful stem cell therapies even for the eye. The most expensive drug in the world is the treatment for LHON. So just like that, we might have some stem cell therapies for glaucoma in the future. And of course, brimonidine, ROCK inhibitors, these are neuroprotective agents which are currently in use. We have several compounds with antioxidant function, which has been shown to improve the visual fields, or at least maintain the visual fields. And most of these work by improving the ocular blood flow. Other than this, there is some physical devices. So one is by Dr. John Berdal from Vance Thompson Vision. He theorized that the pressure differential can be altered by using goggles with a vacuum pump attached to it and would be worn overnight. So these are the balance goggles and multi-pressure dial from the company Equinox, which he made. And these are supposed to be worn when the patient is asleep. And this has a suction and vacuum suction, and that is supposed to reduce the pressure differential and improve the visual field in normal tension glaucomas. Alzheimer's and glaucoma seem to have some connection because both are neurodegenerative disorders. Alzheimer's has been shown to be due to protein misfolding. Maybe glaucoma has some component of that as well. And even though diabetes type 1, type 2, type 3 in medical textbooks have been classified as these. Type 4 is gestational diabetes. A different classification by Dr. Suzanne de la Monte. She had theorized that Alzheimer's can be classified as a cerebral insulin resistance, which she called type 3 diabetes. Similarly, glaucoma would be a visual pathway that is again in the brain, insulin resistance, which would be type 4 diabetes. So insulin might have some role in treatment of glaucoma in the future. May not be directly insulin, maybe some analog of insulin which crosses the blood-brain barrier. And so this is because aberrant insulin signaling in the retinal ganglion cell has been triggered by raised IOP, which causes mitochondrial dysfunction, apoptosis, damage to optic nerve head, and synaptic degeneration, which results in optic disc cupping. So this aberrant insulin signaling is part of the process. Initiation and sustainment of this neurodegeneration in normal tension glaucoma also happens. So that is through accumulation of amyloid beta and tau proteins, misfolded proteins. And so this is a relationship between Alzheimer's and glaucoma. And so as we saw earlier, insulin might have some role in the treatment of glaucoma in the future. And this is from AIMS Delhi RP Center, where they have discussed that insulin might be a therapeutic agent for glaucoma. Artificial intelligence is very, very useful in the diagnosis of glaucoma, and it might also help in the treatment of glaucoma. So all the OCT and images which we scan, they are segmented into the various layers by artificial intelligence. So that is something which is which we didn't even look at. It is automatically done by artificial intelligence. In addition, the Sensimed triggerfish IOP monitoring contact lens, it uses artificial intelligence to convert the changes in curvature of the lens to intraocular pressure. And of course, the segmentation of ASOCTs by artificial intelligence. Glaucomatous cupping can be looked at. OCT can differentiate glaucomatous versus normal OCTs. Visual fields, all the criteria can be Anderson-Patterson criteria can be automated by artificial intelligence. AI can differentiate between the glaucomatous visual fields and normal, and learning defects and otherwise. Analyze these fields, and it is used to analyze frequency doubling perimetry. And it can detect slow progression, because even minor variations, which is difficult for human ophthalmologists to pick up, can be picked up by AI. And in addition, AI has been trained. This particular group, Wenley et al., they trained a system, an AI system, to predict the future visual fields for the next 5.5 years based on the current visual field which you give and the target IOP which you give. So it can predict at what target IOP what will happen to the visual field, and this will help in treatment. So this can lead to customized treatment for every patient based on their previous visual fields, current visual fields, IOP trends, and the target IOP. So this is another group which also did the same thing, which helped to pick a target IOP for each patient. That's all for now. Thank you to all the institutes where I learned, and thank you for present.
Thank you very much, Dr. John, for enlightening us so well. And really, I got to know about your Equinox goggles and the role of probable insulin in the future management of glaucoma. Okay, now going on to the panel discussion. First of all, I'm sure all of us here will agree with me when I say that that we actually should practice evidence-based medicine, and that is possible only if we keep ourselves updated actually with the randomized controlled trials, the lectures that we have listened to today. And the idea of listening to them is to actually implement certain recommendations from them in our clinical practice. So my discussion today, directed to the panelists as well as the speakers, will be to give take-home messages in various sectors of glaucoma on what exactly we can recommend for practice. So first of all, going to the primary angle closure disease, Dr. Bhaskaran enlightened us on the ANALYST trials and the ZAP trials. So to the panelists here, even though Shweta is introduced, I would see the panelists and just repeat. Dr. Srini, who's known to us all, then Dr. Nimita from Comtrust, and Dr. Smita from Little Flower, Angamali. So, are you all here?
Yes. Yes, ma'am.
Yeah. So the first question is that not all primary angle closure suspects need to undergo laser iridotomy. That was what Dr. Bhaskaran actually explained to us through his the ZAP and the analyst trials. So I would like you to one of you to consider, say, Dr. Smita, if you could consider in your clinical practice, what would you consider as high risk factors when a laser iridotomy would be beneficial?
Yeah. I will do ACTI in patients with family history of acute angular attack. Then the other fellow eye acute angular attack. And if patient is diabetic, and if patient cannot be followed up.
Okay.
Such cases I do ACTI.
Yeah, if you could just enlighten us on the background of what was elaborated in the trials. Like Doctor said, Dr. Bhaskaran just emphasized that diabetes and family history of glaucoma was not included in those trials, which is the limitation of those trials. But definitely, and the number that he came up with, 20, if you treat 20, you probably can prevent one from going from a primary angle closure suspect to a primary angle closure. So amongst the risk factors, anything else, Dr. Srini, that you would like to put in, which was not probably included in those trials?
Madam, I think Srini sir is currently not.
Okay, Dr. Nimita. Anything you think apart from what she has mentioned?
Mainly, I think so. The provocative test, which a positive provocative test will require a YAG PI.
No, I don't know. I don't think we are practicing the provocative test, but I do feel that one of the limitation here is that the lens vault has not been taken into account. And Dr. Bhaskaran, can you elaborate on any other risk factor?
Yeah, lens vault seems to be one of the diagnostic features in looking at angle closure. They have used it in some of the AI thing and all. But as such, we actually looked into it in the analyst trial, as well as we put together the ZAP as well. And it has not been published yet, but I think it didn't come up as a risk factor, unfortunately. I think it may be to do with, patients are actually, we see, they're all going through cataract extractions in between. So we cannot really have a real world situation there. So in the initial baseline case, lens vault, it didn't show any difference. So maybe in a very extreme case, because even primary angle closure glaucoma is advanced sometimes when the lens vault is very high. When we try to remove the lens, the IOP drops down, and we don't have to do a glaucoma surgery in those patients. We can keep them on one medication; it works. But that's a very, very rare cases, and I think you need a large number to really look into that as a real risk factor. So at present, based on just the higher lens vault, we don't go for maybe extremes. So one of the things which they found is more than 800 microns lens vault. Maybe you can, think about an early cataract extraction. That's a possibility. That's why I said a small group of patients may require this early cataract extraction.
Yeah, thank you. So I think to sum up, in considering the risk factors, a high IOP, if you want to exclude the lens vault, we take it off. But a baseline high IOP, a family history, diabetes, and like Dr. Thomas has raised it in the quest, that other patient factors with respect to them not being able to follow up to the base hospital, etc., can be considered as some of the salient factors to be considered in considering a laser PI in patients for it to have a benefit in preventing progression to PAC. But all the same, I would like to emphasize that if you can follow up your patients properly, you can afford to not do laser PI in a good subset of patients. But you should be able to follow them up, which is a little difficult in our setup, isn't it? Yeah, now moving on to the open angle, and of course, another discussion about the EAGLE study. What is your take on it, Dr. Smita? I think we have very little time. So if you can just put in your.
If the patient is having PAC and having cataract, significant cataract, it's better to do cataract extraction.
I think that in a vast majority of patients of primary angle closure disease, a lens extraction actually is not very much applicable in the moderate and advanced glaucoma groups. Only for patients who have more than 21 IOP and the early, probably we can consider. Isn't it, Dr. Bhaskaran? Anything you want to put in?
Yes, that's the thing. And as they said, inexperienced surgeons doing cataract extraction may result in increased rates of complications. Even the experienced surgeons had so many complications in that study. So that is only a small number of patients, 400 patients. So if they're going to do across the board, then it is going to create more problems. Angle closure patients need to be handled very carefully, and it needs a bit of a different approach as well. Of course, having said that, definitely there is a small niche area that is really will benefit by cataract extraction, early cataract extraction.
Yes. So lens extraction and angle closure glaucoma is more complicated than a regular cataract. So then next, we move on to the open angle glaucoma, where we would be covering the ocular hypertensives, the normal tension glaucomas, and the primary open angle glaucomas. So Dr. Smitha, what is your take on the treatment of your ocular hypertensives? We have Dr. Kamla has already elaborated the risk factors, regarding the CCT, the level of IOP, the PSD, the vertical cup disc ratio, etc. Amongst them, how do you implement in clinical practice? What is your
If the IOP is more than 26 or 28 millimeter mercury, and if there is any family history of glaucoma, or if the cup disc ratio is more than 0.7, with this risk factors, then I usually treat.
Okay. Anything else, Nimita?
Madam, then CCT will be taken. Older patients basically will be taken more into risk, high risk patients as a high risk patient.
Yeah, so I agree with both of you, and I would put forward as CCT and the thin CCT as a major risk factor in consideration of treatment of ocular hypertensives. So regarding the OATS 3 and the 20-year follow-up that Dr. Kamla just elaborated to us, Madam, what is your take on the practice of which has included, not in the analysis, but they have included the RNFL analysis from the OCT as one of their parameters, which they have not included into the analysis, but they have been doing it in the follow-up. So what is your take to the message to the practitioners on OCT RNFL in ocular hypertensives?
Yeah, actually, both. I would rely more on the HFS swab and the OCT. I mean, take both the reports together and then evaluate the risk factors of the patient. And here I would like to tell that the family history of glaucoma, which we keep talking about so often, it is very difficult to practically elicit a family history, because not many patients, they know whether there is the glaucoma related blindness in their family. They would not give a proper history. So I would probably rely more on the clinical findings, and of course the OCT RNFL swap results. I would take it more often, probably say 4 to 6 months in the first 2 to 3 years, and then I would decide whether what frequency I would like to do it in. And the other risk factors which were told in the OATS trial would also be very high on the priority list to start the patients on medications.
Yeah, thank you, Dr. Kamla, ma'am. I think it's quite clear. And now moving on to the normal tension glaucoma, Dr. Smitha, what is your recommendation on management?
I will see whether the I will start on anti-glaucoma medications and see if there are any other factors accounting for glaucoma for this optic nerve damage other than the IOP.
What about you, Nimita? Anything else you want to add in?
Basically, in this normotension people, patients, we are supposed to look if there is any, if they are on beta blockers, and also the role of whether there is disc hemorrhage. They are more likely for progression. So we are supposed to look into that also. And lowering the IOP is the key to this. Basically, we use Dozox.
Yeah, because it is considered to have some role in ocular blood flow, I guess.
Yeah.
Yeah. So like you said, the level of IOP and the risk factors like migraine and disc hemorrhage carry importance. And so surgery in normal tension glaucoma, Dr. Kamla, is it reserved only for the advanced visual field loss? And what is your take on the unilateral NTGs?
I didn't get your question, ma'am. Sorry.
Yeah, like she just covered about the level of IOP and the risk factors like disc hemorrhage and migraine. So I just wanted you in your, when you elaborated the CNTGS study, you mentioned about doing surgery only for those with advanced visual field loss. So your final word on surgery in normal tension glaucoma and your opinion on managing the unilateral NTGs.
Okay, NTG, actually, we need to be a little bit more careful than the POAGs. And most of the NTGs which I see, they're very, very slow progressing. So many of the NTG patients actually never require surgery. That is what is my clinical experience, this thing that, most of the times they are doing pretty well with drops. And this fact that the NTG does not progress so fast, we can be, it will be, probably prudent to delay surgery as much as possible. So with drops, if you're able to manage it, I would like to do it with the drops itself. And the other part with NTG is that you need to make sure that there is no neurological problem like a space occupying lesion and all those things. You should get your imaging and all those things to make sure you're dealing only with glaucoma, especially with a unilateral NTG, which is not relatively very common. So you should make sure that you're not dealing with something else. You are just looking at glaucoma, trying to treat the IOP or trying to treat the progression and all those things, but probably there's something else the patient needs attention to. So we need to make sure that these things are first sorted out before we actually embark on surgery. So
thank you, ma'am.
As far as NTG is concerned, because of its slow progressive nature, I would like to maintain as far as possible on medications before I actually go on to surgery.
Okay. Thank you, ma'am. And Dr. John, anything to comment with all the drugs you told about, memantine, ginkgo biloba, and ocular blood flow analysis, etc.? Anything you want to add, put in as an addition to treatment of NTG?
Yes, ma'am. So as you already told earlier, ma'am, many of we need to follow evidence-based medicine, and many of these things do not have enough evidence. And sometimes the evidence points in one direction in some studies and in the other direction in some studies. So even though there have been studies which show benefit with some of these drugs, maybe only a few, such as brimonidine and some ROCK inhibitors and a few things such as that, have actual evidence in their favor. So maybe we should look for more neuroprotective agents. Maybe we should look for better studies to find out what we are missing. So we'll have to look, further studies are required.
Yeah, Dr. Bhaskaran Mani has just proposed the ongoing trials on nicotinamide as well. And so now moving on to the ocular hypertensives as well as the early to moderate open angle glaucomas. What is the take of Dr. Smita on SLT? And with the SLT and the light trial and the the SALT trials that Dr. Bhaskaran Mani proposed, in the light of that, can you just elaborate on the current status of SLT, which I still feel is in our country is still underutilized and it's not really in vogue. So you can just put in your view, and the final word will be given by Dr. Bhaskaran. Dr. Smita.
I think for early open-angle glaucomas and ocular hypertension. Hypertension, we can give SLT. But for moderate and advanced cases, I don't think it would be effective.
Dr. Nimita, anything to add?
SLT is probably safer. I have nothing else to add.
Okay, Dr. Bhaskaran, please give the final word on the repetition, the light trial recommendation and the repeat SLT beneficial effects.
Yes, as you said, it is underutilized probably because of practicality of having the machine in the clinic. So, but I think, with the newer machines which are coming with integrated multiple types of lasers, I think SLT should be practiced more because it is a safer procedure, easier to do, and you can repeat it as much as possible. But then your word of caution, once the outflow channel is kind of like in moderate advanced glaucomas, it's not going to work because it's going to be beyond collector channels and all is going to be blocked. Then at the Schlemm's canal level, then I don't think this is going to work because it's going to change the trabecular meshwork and do it. So that way, I think SLT is being underutilized and we should be doing it. And 360-degree treatment can be done without fear. And of course, IOP spikes are very rare. Check for it after an hour or so, and then the patient can go 2 months. We can see the effect. And if it is not happening, maybe 3 months, we can repeat it. So I think there are some schools of thought where they have to wash out the medications before doing it, so the effect actually becomes better. But it can be done with the medications continuing as well. I do it in ocular hypertensive patients, open-angle glaucoma, mild, slightly moderate glaucomas as well, and even add on in patients who cannot go for surgery. Also, so I think it's underutilized and we should be doing more, especially in our country situation.
Okay, thank you. I just want one more you to answer one more question which has come in YouTube as to the PSCS patients. One of them have raised a question that in PSCS patients on whom the provocation test comes out positive, what is your level of line of management after that?
Provocation test itself is not a problem or a risk factor. But probably that may be an indication that these patients are prone for rise in AOP. Probably, as you said, the lens wall could be higher, or maybe they are closing up, the lens may be loose. So I think those patients, one need to be cautious about dilation. And one of the things which we talked about, majority don't progress, so we don't do any laser in 90% of the eyes possibly. And those patients, when we are dilating, I usually give 1 tablet Diamox. So that there is some aqueous suppression and the pupillary block when the patient goes back home doesn't happen. So that is something which we can do it in these patients whom you are considering as high risk when you are dilating or accidentally dilated. So that has been done in the analyst trial, and actually the acute primary angle closures happened because of some other reason and not because of dilation.
Thank you very much. And my last question now to the panelists, that will be to cover the surgical trials. And in that, I would like to, Dr. Kamla told us about the TBT study, the primary tube study, as well as Dr. Bhaskaran covered the TACs and the advanced glaucomas. So putting all this into the picture, we see that the tubes are very much coming into the forefront as a first line. So in clinical practice, what is the situation? Can you just give us brief idea, outline, like Dr. Smita?
If I usually do it in the trap phase, or if it is a secondary glaucomas like neovascular glaucoma, uveitic glaucoma, such cases.
So when trap fails, you go for tubes. Dr. Nimita?
Yeah, basically in severe advanced damage where failed trabeculectomy, where there is a failed trabeculectomy, tube is done, and also in retina post retina cases, also tube can be done.
Okay, and final consensus from Kamla madam. Where do tubes in modern surgical approach to glaucoma management stand? And amongst the tubes, the valved versus the non-valved, which gets the preference when you have an uncontrolled IOP, advanced glaucoma, and you want a low IOP, and not so low IOP. So when exactly you want the valve and the non-valve, and where does the tube going to be
Presently,
stand?
despite the TVT study and the PTVT study, I don't think we are using tubes for primary glaucomas. So it is still in our clinical practice, it is still for the refractory glaucomas, like for your post-VR surgery glaucomas or neovascular glaucomas or uveitic glaucomas. So as of now, I am not doing primary tubes for a primary open-angle glaucoma. So still going with trabeculectomy, and probably trabeculectomy is, of course, both the surgeries are kind of balanced. Not that tube surgeries are difficult. Actually, it's a very simple surgery to be done. But the complication rates, we have to look into it. And then as even in the both the studies, they have told that, the surgeon's skill is very, very important, which has not been studied in either of the studies. So we need to look at what best works in our hand. The studies and all, they have given us a direction, yes, but then what works best in our hand is something which we have to look into. And as far as the both the surgeries are concerned, a copious amount of counseling is what is required to be told to the patient, the pluses, the minus, and at the same time, you should also be ready to manage the complications of both the surgeries. So if you are able to do that, then I think any of the surgeries should be doing fine. But then as of now, if I have to give one word answer, probably my balance would tilt towards trabeculectomy more than the tubes in primary glaucomas.
Thank you, ma'am. So finally, it is a surgeon's skill which matters a lot in decision making, and the patient's viewpoints and considerations ought to be incorporated in as well.
Absolutely, because nowadays patients are also they look up a lot of things on Google, and they share their reports on WhatsApp to other surgeons and the friends of friends, and all these things are happening. So you need to be extremely careful as to how you're going to go about in advising patients and operating them and managing them post-operatively.
Thank you very much, ma'am. And so finally, to Dr. John, you showed us Octa, you showed us ocular blood flow. What amongst this amongst all of these that you showed, we can carry on to practice further in glaucoma management?
As always in glaucoma, it is never one investigation. It is a combination of all the investigations. So I think we cannot rely on just one of these modalities. We will have to use, in addition to OCT and HFA, we'll also have to probably look at the Octa, maybe a different type of more reliable field testing method also, and also the ocular blood flow. And maybe we will also look at something beyond. Maybe we will look at some sort of neurodegenerative markers, and that would be the future of what we will need to do in glaucoma. Not rely on one particular modality, but a combination of all these.
Exactly, and we'll never forget that about nocturnal hypotension and orthostatic hypotensions, I think. So thank you, Dr. Shweta. I think I am handing over to the next session. And very sorry for the YouTube questions if I have not been able to cover. You can approach the speakers directly with the questions. And thanks a lot for the excellent talks, Dr. Bhaskaran, Dr. Kamala, and Dr. John. And thanks to KSOS. Dr. Shweta, please, can you take over?
Thank you, everyone.
Thank you, ma'am. That was indeed an excellent discussion by our speakers, panelists, and of course, the chairperson on trials and research. Now, we are going on to our next sessions. The session is on investigations in glaucoma. So in our session, I invite Dr. P. Satyan, sir, who is a director and head of the glaucoma services at Satyan Eye Care Hospital, Coimbatore, as the chairperson. And along with sir, we have the panelists for the session, Dr. Sai Kumar, sir, who is a KSOS president, who is from Giridhar Eye Institute, Kochi, Dr. Raki Dicruz from Ahalya Eye Hospital, Kottakkal, and myself, Dr. Shweta from Jyotis Eye Care, Kannur. We welcome the eminent speakers of the session. I would like to introduce all the three speakers together. First speaker for the session is Dr. Gauri J. Murthy, who is a senior consultant glaucoma and cataract service, Prabha Eye Clinic and Research Center and Vitla Institute of Ophthalmology. She has published papers in national and international peer-reviewed journal and is an invited faculty for more than 150 meetings in India and abroad. We welcome you, ma'am. The second speaker is Dr. Jatinder Singh Bhalla. Sir is a secretary of Delhi Ophthalmic Society, member Scientific Committee AIOS, and chairman Scientific Committee ISMS ICS. He is an alumnus of Maulana Azad Medical College, New Delhi, and presently senior consultant and academic in charge of DDU. It is difficult to summarize his achievements in a sentence or two. As you can see, he has achieved lots of awards. I also welcome you, sir, for the meeting. Next speaker, we have Dr. Manoj Prathapan, sir, who is an associate professor of ophthalmology at Amrita Institute, Kochi. Now I hand over the session to our chairperson, Dr. Satyan, sir, for chairing and moderating the session.
Thank you, Dr. Sweta, and thanks KSOS for inviting me to be the chairperson for this session. Without wasting our time, probably we'll just go for the talks first, and then we'll have the panel discussion once the topics are over. Dr. Gauri, please.
Yes, sir.
Dr. Gauri, are you ready, please? Yeah.
Yeah, I'm ready. I'm just sharing my screen. Thank you, Dr. Shweta, and thanks, Dr. Satyan. Are you able to see my screen now?
Yeah, we can.
Yeah.
So,
thanks,
KSOS, probably.
Thanks. Yeah, thanks, KSOS also. Definitely, Dr. Satyan. Thanks for reminding me that. My talk is basically focused on the art of detecting artifacts, because when we are diagnosing glaucoma, we base our diagnosis on these diagnostic tests. So the better you are at detecting something which is not glaucoma, the better you get at detecting true glaucoma. So as Leonardo da Vinci said, learn how to see and realize that everything connects to everything else. This is particularly true with respect to glaucoma, because they are all pieces of a jigsaw puzzle that you put together. Coming to visual fields, remember that the test subject is a human being. He is prone to being imperfect and is influenced by external factors. The same is true of the person administering the test, the technician, and the same is true of the person interpreting the test, that is us. So to err is human. So let's look at the errors which could happen. There are test-related errors, which are patient and technician-related errors and defects due to other pathology. So let's go through some of them. Many of you are familiar with most of these, but I would like to reiterate for the benefit of those who would like to learn. So in this particular field, you can see that the fixation losses are very high. But then the gaze tracking, if you see, it's not too much of a fluctuation. Why is this happening? If you look at the blind spot location, see this triangle indicates where the blind spot has been initialized. So in the initial part of the test, the blind spot has been located to this portion, which is in a wrong location. So the patient's head was probably slightly tilted, or the position was little shifted. Subsequently, the perimetrist has corrected the position and the true blind spot is here. But then every time the fixation loss is being checked, it is being checked here. And that's why you've ended up with this 16/21 blind spot, fixation losses. So you can see that once the blind spot is correctly initialized, the fixation losses go down to 0/20. So this usually falls between the 10 and 20 degree mark on the horizontal meridian, and below the triangle is usually a 0. That is the clue for you that this blind spot has been initialized well and the patient has done a reliable test. So the next thing is a trigger happy patient. See, examples like this are very easy to detect where there are typical white scotomas. But a subtle clue for you is whenever there are spots which are more affected in the pattern deviation plot than in the total deviation probability plot, that means that the patient has false positives. So looking at this field, you may think that this is an inferior arcuate scotoma, but then look at these points. You can see there is a sharp drop off. The points at 0 and the right next points at 32, 31, which have good threshold. And also this is not like an arcuate, which is narrow here and widens as you go nasally. So you can see that this is in fact a rim artifact. And once the rim was positioned properly, the field turned out to be normal. So another artifact which comes up is due to ptosis. So you can see here again, this is something which is there only on the superior portion. So if you can see, these two lines are 0, 0. So this is definitely due to the lid which is coming in the way of the visual field testing. This is an additional edge artifact, but then this portion is definitely due to the lid causing the problem. So things like this is a clover leaf defect, but this is an initial attention of the patient. These 4 points are tested first during the test. So first 4 points when they are tested, patient is attentive, and subsequently he has gone off to sleep, which is reflected over here also, 62% false negatives. Whereas here, the patient doesn't know how to do the field. He started figuring out. The perimetrist has not given proper instructions. First 4 field, he is unsure. So only these 4 field points are normal, and subsequent all the points are normal. Again, this is a reliable field except for slight fixation losses. Here, the instruction has not been given properly. Patient has learned along the way. Another one, a defect that I would like to bring to your notice is you may find fields where the blind spot is just down over here, or you have a superior hemifield, arcuate type of a defect which corresponds to the horizontal meridian, but in a subsequent test, it's just dropped down. Is this a new inferior defect, or is it something which is an artifact? This is nothing but the failure to refix it at the central point. See, the first part of the test the foveal threshold, and this is done by looking in the lower half of the bowl between the 4 lights. So if the perimetrist has not told the patient to fixate at the central point after doing the foveal threshold, then patient keeps fixing down there and completes the field. So the entire field shifts down, including the blind spot. So this is what you see. So this is nothing but a dropping blind spot due to failure to refixate. What is this defect? Is this an inferior arcuate scotoma? No, this is due to the mask. With COVID-19, we saw a lot of these defects. The mask can come in the way of the visual fields as well, and one should rule out the effect of the mask in the defect that you are getting. We have been taught that media opacities cause only generalized depression. Media opacities can cause localized loss as well. See, this corneal problem cause this defect. And these spokes which are there in the cataract, the localized opacities, cause these points, these localized defects. So you need to correlate with the disc picture and the fundus, the anterior segment picture both. So is this glaucoma? This is showing respect to the horizontal meridian predominantly in the inferior hemifield. No, this is because of a branch retinal vein occlusion. You can see that there is an occlusion of a vein over here, and this area has been affected and laser. So that is the reason why you are having this field defect. So is this defect due to glaucoma? Again, you can see this is a nasal defect which is respecting the horizontal meridian. But when you look at the fundus, you see this, and it's very clear that this is due to this finding and not due to the disc finding. So correlate, correlate, correlate. Next, we go on to the OCT. How does the OCT detect glaucoma? By retinal nerve fiber layer thickness and by macular and ganglion cell layer thickness. So the first thing that you will do when you get an OCT printout is to check the quality of the scan. So scan quality definitely affects OCT performance, and it is greater on the RNFL than the ONH and the GCC. So cataract is a major culprit, and various machines have various acceptable signal strength levels. You should know what the threshold for your particular machine is. So next we come to operator related artifacts. See, when you see this pseudo color image and you're seeing these black spots, that means there is missing data. These missing data can be due to blinks. This is due to a blink. This can be due to improper scan centration, head tilt, and inaccurate taking of the scan. This is a technician related error. Sometimes the scans are truncated like this. You can see the top part of the scan is cut off. So these kind of scans cannot be reported. One should be wary of that. And there are certain other eye structures which can interfere with the imaging. Here you can see there is a PVD which is occurring, and this PVD causes shadowing of all the posterior structures, and the image of the optic nerve head and the retinal nerve fiber layer will not be a good one. Again, there is a small vitreous opacity over here, and you can see this is causing a improperly absent signal over here. That's why this is white colored, and you can see the Tisnet graph just dips. There is no information about this area because of this vitreous opacity. So look at this in the printout, and if you have access to the machine, it's much easier to pick up these artifacts. So now if you push the calculating circle outside. So instead of calculating here in the first circle, if you push it outside, it goes outside of this opacity. And now you can see that you get meaningful information. So you need to change this as you are doing the interpretation. Blood vessels can cause shadowing, like you can see over here. And in this particular patient, this prominent blood vessel has caused a apparent increase in the thickness in this quadrant. So you should be mindful of this also. And myelinated nerve fibers, they cause an apparent increase in the RNFL thickness. You can see here, the spike just shoots up here. That is nothing but this myelinated nerve fiber bundle over here. And MNFs also cause backshadowing because they're quite opaque. And OCT is a light dependent technology. So the posterior substructures are not imaged. So the Brooks membrane opening is an important thing which is calculated with the spectralis, based on which the minimum rim width is calculated. So you can see here, sometimes the BMO is calculated inaccurately. So you can see the disc is here, but then these red dots are what the machine has calculated. And this kind of an inaccurate BMO detection has caused this borderline notice over here in the minimum rim width. But if you correct the BMO opening, you can do that. You can edit the points. You can see that this goes back to being green. So one should be mindful of the BMO. Next is a centration. Scans which are like this, which are not centered, do not provide accurate information. You need to be wary. Again, here there is a PVD occurring. There is traction on the retina. So there is an apparent increase in the thickness. You can see this graph is off the charts. So this is not true. So again here, if you widen the RNFL calculations circle, you're going beyond the traction and you get a meaningful scan, which can be used for diagnosis and for follow-up. Segmentation. See, the OCT determines the anterior and posterior extent of the RNFL. So this can be erroneous sometimes. Like you can see here, there is an anterior segmentation error. The segmentation is misregarding or disregarding a part of the RNFL, and that's why you get a borderline over here. And the same can be true of the posterior segmentation as well. So you can see here, the posterior segmentation is very inaccurate, and these kind of scans will not be true in their interpretation. Here again, you can see the segmentation artifact. Here, both the anterior and posterior lines are fused together. And that's why you can see here that the thickness has dropped below the floor. So this kind of a segmentation artifact you should look for. They are there on the printout. You need to be mindful of them. In a patient with high myopia with peripapillary atrophy, these kind of artifacts are more common. And many times OCT is meaningless in such patients with myopic discs and peripapillary atrophy. Finally, green disease. So a cursory glance on this scan shows everything to be green. So can we say that this patient does not have glaucoma? No. If you can see this, there is an RNFL defect over here. And if you look at the GC-IPL map, it's very obvious. There is a gap over here. So this is a dip in the superotemporal RNFL. This patient definitely has clear-cut RNFL loss and has glaucoma, and you should not miss that. Another printout, here everything is green. Even the GC-IPL looks very healthy. So does this patient classify as normal? Look at the red-free picture. You can see 2 bundles of RNFL defects here and a wide RNFL defect over here. So this is there on the testnet graph. You can see that it is dipping into the red here and it is dipping over here. So you should be mindful. You should look at the clinical picture and then correlate. The RNFL thickness is showing borderline, whereas the minimum rim width was normal. So you should look at the scan and look at the circles, and you should look at what is reliable, what is not, and then only you should decide whether this patient has glaucoma or not. Look for segmentation errors, examine the testnet RNFL plot and make note of whether the location of peaks correspond to the peaks from the normative database. Correlate the GC-IPL map with the testnet graph. Look for presence of tilted disc and peripapillary atrophy and be aware of the artifacts, and recognize that ocular disease can create errors in segmentation, and most importantly, correlate with clinical examination. These tests, whether it is the field or the OCT, should never be viewed in isolation. It has to be looked at within the context of the clinical picture, and each one should correlate with the other. So as I'm repeating the quote by Leonardo da Vinci, develop your senses, learn to see, and realize that everything connects to everything else. The more you are aware of artifacts, the more you can accurately diagnose glaucoma. This is a leaf-tailed gecko, which is very, very nicely camouflaged on the branch. Defects are also like this, and one should be alert to detecting these defects. Thank you.
That's a wonderful talk, Dr. Gauri.
Thank you,
And
sir.
what are the best OCTs that you are using? So you are, I think, really enjoying the OCT. That's why
Yes,
you're
sir.
able to detect so many defects, especially with the separation of the GCL from the IPL. Probably we'll have a detailed discussion.
Yeah.
We'll go on with Dr. Jatinder's topic on modalities for imaging in glaucoma. Over to you, Dr. Jatinder. Dr. Jatinder, can you hear me?
Yeah.
We can see your slides. Yeah.
Yeah. Am I audible, sir?
Yeah. Please.
Okay. Good evening, everyone. Good evening, Dr. Satya and Dr. Gauri. First of all, I thank KSOS and Dr. Srini for giving me this opportunity. The topic I am going to cover is modalities for anterior segment imaging in glaucoma. My slides are not moving. Yeah. So visualization of anterior chamber angle is a very critical step in the diagnosis of glaucoma. And we all know that gonioscopy remains the clinical gold standard for the diagnosis of narrow angle. But this method, although the gold standard, it has some limitations, like it is subjective, highly dependent on the examiner's skill and interpretation, depends on the patient cooperation, and the closed angle or narrow angle may erroneously appear open if too much pressure is exerted or if too much light is shown into the eye. So we have some anterior segment imaging devices, and the common ones are anterior segment OCT, UBM, and also sheen plug photography. And the recent addition to the armamentarium is ICAM. Anterior segment OCT, it is a non-contact rapid imaging device, and it uses the principle of low coherence interferometry to obtain the cross-sectional images of the anterior segment. We all know there was time domain, which has all it's almost obsolete. Then we have the spectral domain, and now we have the swept source OCT. And the advantages of swept source, we all know. I won't go into the details. It has a higher scan rate, high resolution images, and the swept source shows the peripheral anterior synechiae much better than the spectral domain, which and also it is very good at calculating the iris volume, which has shown to be an important determinant of is anterior chamber angle parameters in angle closure disease. So biometric analysis of the anterior chamber angle, it all requires a reference landmark, and that reference landmark is scleral spur. And there are various methods to determine the position of the and variables and smaller anterior chamber depth or narrow angle, shorter axial length, older age, they can all increase the difficulty of accurate identification of this very important parameter, that is identification of the scleral spur. And several studies have shown the various techniques to best identify the scleral spur, and the three commonest techniques are: one is location of Schwalbe's line, which is relative to the scleral spur, then intersection of the ciliary muscle and the inner corneal margin, and bump-like structure in the inner corneal meshwork margin. And if we compare the anterior segments OCT with the gonioscopy, we find that anterior segment OCT is more objective, non-operator dependent. It is non-contact, so comfortable for the patient, can be performed in the dark. It is excellent as objectively measuring the iris parameters like iris curvature, area, and thickness. And it gives us the snapshot of entire anterior chamber in one scan. But what are the limitations? It gives us cross-sectional view, so not practical for scanning the full 360 degrees. Cannot assess the angle features other than the angle width. Indentation is not possible. And several new anterior segment OCT parameters have now been associated with angle closure, and these parameters are smaller AC width, area, volume, larger lens vault, as was told by Dr. Bhaskaran, greater iris thickness, and anterior chamber area, volume, and lens vault. These are the most important determinants of angle parameters in the angle closure disease. So there are future OCT such as ITC index, which are likely to be there in the swept source OCT, and automated detection of the scleral spur and reference points are also likely to be there in the future developments of the anterior segment OCT. Now coming on to the UBM, it was developed by Pavlin, Sherrar and Foster in the late 1980s. It provides high resolution imaging of the ocular structures. It provides two-dimensional grayscale images of the various anterior segment structures and evaluates them both qualitatively and quantitatively. It acts on a principle similar to the B-scan. We have the frequencies 35, 50 megahertz. Since there is more frequency, there is more resolution, but less penetration. And it gives us a resolution of about 20 microns axially and 50 microns laterally. But there is limited depth of penetration. And these are the three main components of the UBM machine. There is a transducer, there is a high frequency signal processing, and there is a video monitor. These are the techniques. The patient has to be in supine position, put topical anesthetic drops. Then there is an eye cup, which is filled with the small water bath. And the transducer is placed in the saline approximately 2 millimeters from the eye surface. And reflected light is best detected when the transducer is oriented so that the ultrasound beam strikes the targeted surface perpendicularly. These are some of the pictures where you have to place the cup filled with the water bath onto the anesthetized eye. These are the normal structures. You find that this is epithelium. The first structure is the Bowman's membrane. Then is the Descemet's membrane, which is also seen as a highly reflective line, and corneoscopy differentiated because of the lower internal reflectivity of the cornea compared to that of the sclera. Then this is the main important feature. Scleral spur is the most important landmark in both the and the UBM, and scleral spur is seen as a small hyper-echogenic spot when the line between the sclera and the ciliary body is traced to the anterior chamber. And these are the zonules which are seen. This is ciliary body. Ciliary processes vary in appearance and configuration. And if you compare UBM with the anterior segment OCT, what are the differences? UBM is a contact technique compared to the non-contact technique of anterior segment OCT. We have to use coupling media. Here sound energy is used, unlike light energy in anterior segment OCT. Scleral spur is less distinct in UBM. And posterior lens capsule is better seen on anterior segment OCT, but the structures behind the iris and ciliary body are better seen on UBM compared to anterior segment OCT. And only one quadrant can be imaged at a time in UBM compared to all the four quadrants that can be scanned at once on anterior segment OCT. And UBM procedure is more time consuming and requires a highly skilled operator to obtain high quality precision images. But there are limitations, like because of contact technique, there are risks for infection, corneal abrasion, and of course it is contraindicated in suspected open globe injuries. So the application is basically the quantitative, that is to simple measurement methods such as distance, and we can calculate the distance between the two structures, and angle measurement can be done. So we can measure the thickness of the cornea, anterior chamber depth, posterior chamber depth, IOL thickness, iris thickness, ciliary body thickness, and scleral thickness, but it cannot determine the crystalline lens thickness as it cannot penetrate till the posterior capsule of the lens. These are some of the various parameters. These are AOD 500, which is a perpendicular distance as seen from a trabecular meshwork, which is 500 microns from the scleral spur. And this perpendicular is drawn to the anterior surface of the iris. Similarly, AOD 750 is the perpendicular distance which is drawn from the inner surface, about 750 microns from the scleral spur onto the anterior iris surface. Then we have TISA 500, we have TISA 750. TISA, I'll just tell you theoretically, it is the trapezoid where the anterior surface is by this AOD 500 or AOD 750, and the posterior is from the scleral spur. The perpendicular is drawn onto the anterior iris surface, and this is posteriorly a line is drawn from the scleral spur, and the superiorly this is the inner corneoscleral wall, and inferiorly it is the inferior anterior iris surface. So this, like AOD 500 and AOD 750, we also have TISA 500 and TISA 750. Then we have angle recess area. We have lens vault, which is now gaining importance, particularly the measurement of this in the angle closure disease. And what is lens vault? It is the maximum perpendicular distance from a horizontal line between the two scleral spurs to the anterior surface of the lens. Similarly, we can calculate the anterior chamber width, which is the distance between the nasal and the temporal scleral spur. These are some of the other parameters like trabecular iris angle, trabecular ciliary process distance, iris thickness at 500 microns anterior to the scleral spur, iris thickness at 2 millimeter from the iris root, and iris thickness at the pupillary margin. These are some of the other parameters which can be calculated. This is diagrammatic representation of this. I cannot go into detail due to the paucity of time. So qualitative ultrasound UBM has a role in glaucoma, but it also has role in some of the other subspecialty pathologies. It has very important role, particularly in plateau iris, and this is a very nice paper published by Kumar et al. And they have said that if all these criteria are fulfilled in at least 2 quadrants. And what are these criteria for diagnosis of plateau iris? You find that the ciliary process was anteriorly rotated. The iris root, you will find, has a steep rise from the point of insertion, followed by a downward angulation from the corneoscleral wall. And then there is a presence of a central flat plane of the iris. There is absent ciliary sulcus. To determine the occludability of the angle, we can also perform dark room provocative testing with the UBM to study the spontaneous occlusion of the angle under conditions of decreased illumination, although I'll find that this has much more of theoretical importance. Congenital glaucoma, you'll find some of the features on UBM. You find thin stretched out ciliary body. There is abnormal tissue at the iridocorneal angle. There is abnormal insertion of the ciliary body. There are elongated ciliary processes and elongated zonules. In pigment dispersion syndrome, you'll find wide open angle with posterior bowing of the peripheral iris as shown in the pictures. Peripheral anterior synechia can also be seen on UBM. Then in malignant glaucoma, these are the features. There is extremely shallow anterior chamber angle. There is occluded angle. There is forward rotation of the ciliary body with or without fluid in the suprachoroidal. We can also evaluate the functional status of the filtering surgery, whether the sclerotomy aperture is blocked internally, whether the peripheral iridectomy is patent, whether the filtering bleb is flat, shallow, or deep, and also Tenon cyst formation can also be seen on this. Tube implants can be very nicely seen on UBM. This is trauma showing iridodialysis and cyclodialysis. So angle recession can be very nicely seen. It is the tear in the face of the ciliary body, and ciliary body is still attached to the scleral spur. Zonal ruptures can be seen as seen in these diagrams. Hemorrhagic cyst within the iris can be very nicely demarcated. And this is presence of peripheral iridociliary cyst. So, but there are some limitations. It cannot visualize structures deeper than 4 millimeters from the surface, cannot be performed in the presence of open corneal or scleral wound, requirement of immersion technique and experienced operator to perform the scan, and need for all the patient to lie in the supine position, difficulty to in children, and possibility of causing injury to the cornea if the examiner is not experienced enough. Then there is also Scheimpflug camera photography, that is pentacam or Sirius, can also be used for biometric measurement of the anterior chamber, but it is not, this is how it can be done, but this is not much practiced for the anterior chamber angle parameters. iCam is a new technology which is originally designed to yield wide field photographs of the pediatric fundus, and with modification and inclusion of a 130-degree lens, the device can be used to visualize angle structures in a manner which is similar to direct gonioscopy, and it is a new and objective way of documenting angle configuration. So this is how it is done. In supine position, the lens probe is placed onto the coupling gel with or without direct contact onto the cornea, and to image a particular angle quadrant, the patient is instructed to look in the direction of that angle, and the probe is positioned at opposite limbus to the angle being photographed, and the light from the optic fiber is directed toward the angle of interest. So this is the image of an open angle using iCam, which clearly shows the Schwalbe's line, the pigmented trabecular meshwork, the scleral spur, and the iris processes. So images by eye can be saved, thus allowing comparisons to be made over time. And goniographic documentation by ICAM allows for monitoring of anterior chamber angle parameters over time. And compared to UBM and ASOCT, it does not provide quantitative measurements of the anterior chamber depth, but it provides a 360-degree visualization of the entire anterior chamber angle compared with the ASOCT and UBM, which provide only the cross-sectional views. There are, of course, some limitations. Imaging of the anterior chamber angle takes longer than gonioscopy, about 5 to 10 minutes. Device is more expensive, additional space is required, and effect of supine position would have gravity-related effect on the widening of the lens iris diaphragm, and lens light source from the ICAM can also cause pupil construction and may artificially alter the anterior chamber angle configuration. So in conclusion, the new methods of imaging the angle, although they are more objective, reproducible, non-contact, rapid image acquisition, and which can be stored, quantitative analysis, but none of these new devices at present can replace the conventional slit lamp biomicroscopy and gonioscopy. They can at best supplement the data to your gonioscopic findings, and these new techniques are useful in complementing clinical practice, particularly when gonioscopy is difficult. So tradition, according to me, is not the worship of ashes, but the preservation of fire. So we have to really preserve and propagate the gonioscopic skills in all ophthalmologists. And these objective methods are not going to replace the gonioscopic evaluation of the angle in the near future. Thank you, everyone, for your kind attention.
Thank you so much, Dr. Jatindra, for explaining almost the entire spectrum of anti-segment imaging in glaucoma. So you can stay back and we'll have more questions for you.
Sure, sir.
So we'll have Dr. Manoj to talk to us on the important topic again, on the systemic evaluation for glaucoma patients, which is kind of very much neglected. But I feel it is one of the areas where we need to really concentrate, not only for identifying the disease pattern, and also for treatment. We need to have a thorough systemic evaluation for all the glaucoma patients. Over to you, Dr. Manoj.
Thank you, Satyan sir. First of all, let me thank Dr. Srini sir and Dr. Sweta for giving me this opportunity. I'll be discussing on systemic evaluation for glaucoma. A systemic history and general examination is a must for all the patients of glaucoma. I would give special emphasis on patients with diabetes, hypertension, COPD, and heart disease. These may influence my treatment. Also, special note on drug allergies, especially sulfur. So when to look outside the eye? When we suspect non-IOP related glaucoma progressions. These are a set of patients who have glaucoma and their target pressure is achieved by our medication and the patient is compliant to treatment. And in such a situation when the glaucoma progresses, that is one set of patients. And there is other set of patients who we are not very sure if the patient actually has glaucoma or not. So these patients' indicators would be pallor of the disc and visual field and OCT indicators. Let us take a look at an example. This is a patient who was diagnosed elsewhere as NTG, was put on PG analog and came for a second opinion. On examination, there was a high CD ratio, but there was no classical RNFLD or a neurolateral rim thinning or notching. On visual fields, we can see there was something that looks like a biarcuate scotoma, but on careful examination, most of the scotomas were respecting the vertical midline. Now, when we look at the OCT scan also, the RNFL bundles superior and inferiorly appeared normal, whereas there was some thinning of the temporal RNFL bundles. On GCC map, we can see there is a clear nasal thinning of the nasal GCC. So this is very classical of pituitary adenoma. The patient was subjected for MRI and pituitary adenoma was detected. This is the cliplet that we had present in COC. This is a professor at our institute who came for a routine driving license screening. Patient had moderate intraocular pressure with the narrow angles and a cupping of 0.7. He underwent a HFA, which showed a central scotoma. But on 10-2 HFA, we saw there was this scotoma which was respecting the vertical midline. It looked more like a pie in the sky. A central scotoma, which is respecting a right superior hemianopia. So, suspecting a problem in the brain, an MRI was done. We could see there was a gliosis involving the left occipital lobe, which is suggestive of a chronic infarct. So, the potential tests that we have are complete blood count, pulse, blood pressure, if possible at 24-hour monitoring, sleep apnea study, cardiovascular system examination like ECG, echo, carotid Doppler, MRI brain and orbit. So for all the patients, all this investigation may not be required. Next is lifestyle factors. Many of these should be considered while we are treating our patients with glaucoma. First is weight training. So as you will know, when we are lifting heavy weights, there is breath holding and Valsalva maneuver is there, which can increase the intraocular pressure. Aerobic exercise by itself is good for the IOP. Aerobic exercise and weight loss is supposed to reduce the intraocular pressure. Yoga is generally healthy, but mind you that whenever yoga takes postures where the eye level goes below the heart level, like Shirsasana, when it is done for a prolonged period of time, the amount of IOP rise may be significant enough time for causing damage and progression. Alcohol itself may rather actually reduce the intraocular pressure for a brief period of time, but because of the volume overload stage in alcoholics, this may actually cause a prolonged period of high IOP. Blowing in the wind instruments cause a rise in intraocular pressure, just like weight training. And these professionals have to hold the breath and blow for a considerable long period of time. And this may be causing the reason for causing progression of disease. What about coffee? In moderation, it is okay, but caffeine is known to have high intraocular pressure immediately after the intake. So a person who takes more than 4 or 5 cups of coffee in a day may have a problem with progression because of caffeine. I advise all my patients to quit smoking, especially glaucoma patients. But in the literature, there is no much evidence that glaucoma is progressed because of smoking. What about water drinking? There is a general feeling among the public that drinking a lot of water is beneficial to health. So early morning, they wake up and drink a lot of water. So this can be dangerous to people with glaucoma because the trabecular meshwork is at risk, and sudden increase in the volume can cause a choroidal volume increase, and aqueous production also is increased, thereby increasing the intraocular pressure. From personal experience, while I was doing my residency, we used to have these patients for comprehensive health checkup because it was a multi-specialty hospital. So some of these patients had high intraocular pressure, and when we called the patients back for a detailed evaluation subsequent visit, we found their intraocular pressures were normal. So what was happening was some of these patients were having ultrasound of the abdomen as in the package. So while the patients came to the reception, from there they were asked to drink a lot of water, and then they were sent to eye clinic for our examination. So this should be kept in mind when we are seeing patients on glaucoma. The patient was having a reasonably good IOP control throughout the period, and suddenly one erroneous reading of high pressures, maybe because of something like this, caffeine intake, exercise, or a lot of water drinking. Please keep that in mind before we add a lot of medicines to these patients. Next, coming to obstructive sleep apnea. So what is sleep apnea? During the sleep, patient becomes apneic because of loss of breath. So when there is more than 10 seconds loss of breath, this is considered to be sleep apnea. This happens because of airway obstruction at the pharynx, because of falling of the tongue and the soft palate. So this is a study that we had done in 2017, which showed that there was a higher prevalence of glaucoma among obstructive sleep apnea patients. About 29% of them had obstructive sleep apnea. So how do we test it? It's done by a sleep study. Patient's apnea is monitored. So if there is more than 5, the apnea-hypopnea index, if it is more than 5, it is considered to be positive. And more than 30 is said to be severe obstructive sleep apnea. So apnea spells leads to hypoxia, which leads to vasospasm, hypoperfusion, and direct damage. A subsequent reperfusion may cause oxidative stress and further damage. So obstructive sleep apnea is known to be associated with NTG as well as progression of glaucoma despite IOP control. The good thing about this is that if we can suspect this problem and recognize this problem, it is treatable condition. Mild to moderate cases can be treated by just weight reduction and adjustment in the sleep posture, whereas more severe cases may require CPAP, like a positive airway pressure devices. Sleep position may also matter. Suspect these when somebody is progressing in one eye with a good IOP control in both the eyes. So sometimes the patients prefer to sleep on one side all the time, and because of the pillow pressure, this may actually artificially raise the pressure and leading to progression of glaucoma. I advise all my patients to avoid night dose of antihypertensives to prevent nocturnal hypotension. This is another case of a 60-year-old gym enthusiast. He's a weight trainer. He's in fact a surgeon in our hospital. He had this left eye inferior RNFL defect with a corresponding focal NRR thinning. And the patient had a corresponding inferior arcuate thinning on GCC and corresponding visual field effect on HFA. Patient's intraocular pressure was 14 in both eyes. He is otherwise healthy. So was it a unilateral NTG? That was the question. So here the options were to treat or not to treat. So after discussing with the patient was heavily investigated, CBC, ECG, echocardiography, carotid Doppler, even an MRI of brain and orbit were done, all found to be normal. So after talking to the patient, we decided to observe the patient. The patient was advised against weight training. And currently the patient is under observation for the past 3 years without any signs of progression of the disease. Next is a case of a 60-year-old chronic smoker who presented with left eye diminution of vision of 2 months and recent onset of redness and pain. The patient was also diabetic, had diabetic foot, which was amputated, systemic hypertension, and coronary artery disease. Vision in the right eye was 6/6 and left eye was 6/24, with intraocular pressure of 18 in the right eye and 30 in the left eye. The right eye gonioscopy was normal. The left eye showed raised degrees of peripheral anterior synechias and neovascularization of angle with inferior goniohyphema. Anterior second examination of right eye was normal. Left eye showed mild episcleral congestion and very subtle neovascularization of the iris. Convex examination of the right eye was just showing hypertensive retinopathy changes, whereas the left eye showed dilated central lateral vein. Considering this, the patient underwent a fluorescein angiography, and the arm retinal time of this patient was increased to 28 seconds. So taking this as the clue, we did a carotid Doppler for the patient, and we found that the right eye was partially blocked and the left eye had a complete occlusion of the internal carotid artery. So the diagnosis was ocular ischemic syndrome. The patient was referred to a stroke medicine doctor as well as a vascular surgeon. Both of them advised against surgical intervention considering the high risk of cerebrovascular accidents in complete occlusion. So the patient was treated by intravitreal anti-VEGF and photocoagulation, panretinal photocoagulation, and topical anti-glaucoma medications. So what do we do when there is progression despite IOP control? First, check for diurnal variation, and if you have missed an ankle closure disease. If these are not there, consider sleep apnea, nocturnal hypotension, hemodynamic problems, and neurological problems. Thank you.
Thank you, Dr. Manoj Pratapan. I think all the three speakers had given us a wonderful view on the imaging. Even if you do the visual fields or OCT, what are the pitfalls? And Dr. Manoj has given us a wonderful view on the systemic evaluation. We have wonderful panelists also. We have Dr. Sai Kumar, one of the senior most ophthalmologists from Cochin. We have Dr. Reiki and Dr. Sweta. I hope all the speakers are also there. First, I'll just go through the OCT and the visual fields, starting with Dr. Gauri's topic. The panelists also, please, you can add your thought processes. How often all of you do more than one investigation in glaucoma to come to some conclusion that, okay, this patient has this or that? The first, I'll just go over to Dr. Gauri first, and then the panelists can answer.
Sir, in our institute, the protocol is to do fields, OCT, and corneal thickness, because these three findings, along with the clinical evaluation, we feel is necessary. The only exception is in very advanced glaucomas, where the patient has a 0.9 cup and very advanced field loss. I wouldn't do an OCT probably. But then for most of my patients, it's the OCT, fields, and corneal thickness. This is compulsorily checked for all glaucomas.
Okay, the simple reason to ask you is in a cities, things are a little different.
Yes, sir.
But when you go to the peripheral centers, one is the availability of the instruments or the equipments, and also the cost for the investigations.
Yeah.
So one is in the reality what we are talking, and another is about the completely how do you really go about.
Sir, if
Ideally
asked to
speaking,
choose between the two, then the fields would be the one which I would go for. If you would ask me choose only one machine because you cannot have both, then it is only the fields. I can do without the CCT, I can do without the OCT, but I cannot do without the fields. Meaningful diagnosis and management of glaucoma cannot happen without a visual fields machine. That is the basic minimum prerequisite.
okay. Other panelists, please, you can add your points. First, if Dr. Sai is there, and then we can have the other panelists also. Dr. Sai is there. Dr. Raki and Dr. Sweta.
Sai Kumar sir is not there.
Okay.
So,
Sweta, you can just, yeah, both of you are there, I think. Yeah, please.
Gauri ma'am told, in advanced glaucoma patients, mostly by the time they present, their RNFL values will be very low. For example, it will be less than 60 micrometers something. So mostly there is no point in taking an OCT. But I think still we should take one to document and to show the patient that the patient has reached this stage. And but there will not be any value in following up the patient with OCTs, because the values will be the same and will not show any other it will not add any more information. But
So there's the floor effect which we are talking about.
Yeah. So only then in the follow-up visits, I think 10-2 will be much better to document and to plan our treatment. Right?
Yeah, Dr. Sweta.
Now, I would like to add some points to this. So, sir was telling about the city and the periphery. I would like to say something about the city. When you need a complete investigations, if you are in doubt, there is one more investigation that we can do, that is the ERG. So it is like, if you are in doubt, the OCT and the visual fields give you information only when the ganglion cells are dead. But if the ganglion cells are under stress, that will be picked up more in the ERG. But this is not available in the periphery center. It is there in the cities. ERG gives us the pattern electroretinogram and the PHNR, which will give you the early detection of the glaucoma when you are in doubt. Second investigation is the visual field and the OCT. OCT, if you have the Heidelberg Spectralis OCT, I would suggest a Heidelberg Spectralis OCT because it has the automatic anatomic positioning system and the ganglion cells are given very beautifully. You can, the errors are little less in that. Visual fields, of course, is important, as madam has mentioned, but visual field, the problem is once you have an elderly patient, it is so difficult to have an reliable result in visual field. But for the progression, we definitely need the visual field too.
Having said that, I will just go over to Dr. Gauri one more time.
Yes, sir.
You being using the Spectralis, how often you feel you can just rely only mostly on the visual fields rather than going in for a Spectralis?
Sir, first thing is that we don't view anything.
Do
in
you really
isolation.
feel that visual fields definitely gives you a completely reliable results in every given patient than the objective OCT measurement, especially from Spectralis I'm talking about, not talking about the other OCTs?
Okay. Sir, the one instance is in myopic patients with extensive peripapillary atrophy. I showed you OCT is not going to give too much of information over there. There are
Same way, I think same thing may happen for visual fields as well.
no, but then in the visual fields, you can correlate the retinal pathology with the field defect. And sometimes you are able to distinguish a clear-cut RNFL pattern defect, which is separate from the changes due to the retinal pathology. So the fields, I will see, for example, in a high myope, I will still do the fields every year, but I might not do the OCT because changing fields over time, I can correlate these changes to the change in the remaining neuroretinal rim and the disc findings. So the fields is going to help, but the OCT is probably not going to help. And in advanced glaucomas, as you said, but nothing should be viewed in isolation, sir. I mean, I don't think we will have only OCT or like you need to put them together. And OCT definitely adds to the data that are supplied by the visual fields. And to explain to the patients also, the OCT is very helpful. You can show them the amount of RNFL loss and the the change in the green and red area in the RNFL Tisnit graph. These are things which can help to explain to the patients as well. And only where the image is not reliable, the segmentation is not reliable, there is extensive peripapillary atrophy or retinal pathology which affects the interpretation of the OCT, there I would go by the fields alone and disregard the OCT finding.
Okay. Thank you, Dr. Gauri. With the advancement in the OCTs, especially on the BMO markings, do you really feel that the way we were looking at the OCTs has really changed and gives us a lot of information than what we were really doing earlier?
Sir, as you earlier mentioned, the Spectralis is actually a wonderful machine. And if we, not just the printout, we need to go to the actual image on the machine interface.
That is exactly where I was trying to come to you.
Yeah. So
because most of the people still practicing on the printout patterns, looking at the printouts and coming to some conclusion, which is definitely not a good idea.
Yeah.
We all need to go with the machine's software, try to access in on your desktop, which I feel I am really obsessed to one way or not.
Yes.
But if you really go for that, then you'll understand that is you are missing a lot more in just looking at the printout, especially when you're not seeing how the BMO is marked.
Yes.
And you're going to have a lot of mistakes.
Yes.
And every bit of it, you need to read. All the charts are important.
Yes.
And especially with the Spectralis, you have the GCL separately and the IPL separately, so that you can really visualize what is going on with the GCL and the IPL.
Yeah.
So there are a lot more things that we need to see, even if you are looking at the visual fields or in the OCT. It is just not enough by looking at the printout and you come to some conclusion. Even for the visual fields, if you have the access to your desktop, then you are going to look at even much more, the progression pattern.
10-2 progression is there only on the desktop application, the forum in the Humphrey Field Analyzer. Whereas on a printout, you don't get a GPA for the 10-2. So definitely having it on your desktop is important. Somebody asked, how can the fields be interpreted if it is unreliable? See, every unreliable field should not be thrown into the dustbin. You need to correlate the defect with the pathology. So if you are seeing that whatever you see on the field is fitting into a glaucomatous type of a defect and it correlates with what you see on the disc and RNFL, I don't think there is any need to disregard that field completely. So many times it's difficult.
Thank you, Dr. Gauri and other panelists also. Because want of time, I'm just moving on to the other topics as well. One thing is very important, what Dr. Gauri and other speakers, other panelists were mentioning, that it is not just doing one investigation, you can come to some conclusion. We have to just correlate with all the other things and then come to some conclusion. That's very important. Coming to Dr. Jatinder's topic on the angle imaging, which one you feel is the best imaging technology that you have today? Is it that you want to do multiple things and come to some conclusion, like what Dr. Gauri was mentioning about the imaging, not imaging, the investigations? Dr. Jatinder, you are there?
Yes, sir. Yes.
Because it is not easy for you to cover the entire, all the instruments in one session, but it's very nicely you have covered it. So
no, all the techniques are not required. Like I said, the Sheen-Flux technology, it has very limited utility totally. And ICAM is a new tool in the armamentarium with very little experience. But of the first two which I have talked about, the anterior segment OCT and UBM, both give us very objective evaluation of the angle parameters, and they are very useful. Like after peripheral iridectomy, whether the angle parameters are increasing or not, AOD 500, AOD 750, angle recess area, is there any difference or not? If you find there is hard, then you can also, particularly the plateau iris configuration can be very nicely assessed on the UBM. So you have utility of these important tools, that these objective assessments are useful, but they should not be replacing your standard good old gonioscopy. Gonioscopy has to be done first of all, and along with that, if you can supplement your data with these angle parameters, then they are useful. I use both anterior segment.
Yeah, thank you, Dr. Jatinder. And other panelists, you can add your inputs, and also other speakers, Dr. Gauri and Manoj, Dr. Manoj, and also, of course, if Dr. Bhaskar and other previous panelists are also there, please add your valuable comments. A quick comment, because there's a Dr. Sweta has already mentioned to me that don't extend beyond 8. So quick comments. Anybody else is there?
I think they're muted. They're muted. Sweta, Gauri, and Dr. Thomas, they are muted. You have
only one thing I'd say. ASOCT and UBM are the ones that I would use. ASOCT gives us fantastic anterior pictures up to the angle. And UBM really comes in only if I suspect something that is behind the iris or little beyond the sclera starting, which cannot be made properly with the ASOCT. So they are complementary rather than one against the other one.
Yeah, can you put it in a very simple terminology? We all use it when that is really an absolute necessity, most likely in the secondary glaucomas than in primary glaucomas, or where we really start suspecting something else is going on for us, right? So that is where we all use the anterior segment imaging. The other question for me is just going on to the next topic on the Dr. Manoj's topic on systemic evaluation. I'm sorry that we are not having much time. Probably I'll just take a couple of questions in this on the Dr. Manoj's topic. When we are doing the systemic evaluation, do you really think that we need to have a separate column in our case sheet to detail evaluation for systemic evaluation, Dr. Manoj? And of course, others can also add your comments.
Sir, we have that as in the systemic history. We can include all those things over there. Instead of adding a special area in the systemic history, we can add it there.
Yeah, probably some of the things which hypertension, diabetes, and cardiac evaluation, probably we didn't talk much in this topic because we are covering mostly on the Sirasasanas or water drinking and sleep apneas. Definitely adding all these systemic history, drug intakes makes a lot of sense, because when we are giving the medications, it is going to kind of affect the patient's health system, like especially when bronchial asthma or something is there when you're giving the beta blockers, which we all know. So just when we analyze some of the data, if you really look at the cataract patients alone, at least in our hospital, 53% of the patients, they do have some kind of a systemic illness who has come for a cataract surgery. And we did the analysis for the retina department alone. Then it was almost like 91% of the patients had some kind of a systemic illness. It could be just a hypertension alone or diabetes alone. There are the systemic illness is so high, it is, I feel, is very important for us to evaluate them in a very proper way. If you just ask, do you have diabetes, do you have hypertension, the patient is going to say nothing. So with the questions when we are asking, we have to ask in such a way that they give us a proper detailed history, so that we have all the details for us to really look at what the cause, especially when we are really looking at the progression. One interesting point which I've noticed in your talk is sleep apnea and the glaucoma. Dr. Manoj, to you, is that you are trying to say that the sleep apnea is associated with glaucoma, or when the patient is having glaucoma, they have a high chance of progression when they have a sleep apnea? Because both are two entirely two
There is
different
increased
things.
prevalence from that study that I had showed. There was about 29% prevalence of glaucoma in obstetric sleep apnea. And we have evidence from the literature that it also causes progression despite IOP control.
Yeah. So is that when they have a CPAP, do you think that it will definitely bring down
yes,
the
sir. That is
progression?
why if you can recognize a problem and then get a diagnosis and give the appropriate treatment, a further progression can be arrested.
Yeah. So I don't want to take much of the other session's time. Thanks all the speakers and also the panelists for your valuable time and giving a good thought processes for the audience to think over and practice glaucoma, and a wonderful initiative from KSOS. Thank you so much all for your wonderful presentations and valuable comments. Sorry that we can have a lot of questions and a lot of discussion, but as the session is going to be there next session, I'm handing over the session to the next speakers. Thank you.
Thank you, and good night, everyone.
Thank you, sir. So that was an excellent discussion that we had. Now, because of the lack of time, we are moving on to the next session. So the next session we have on management of glaucoma. So we have management of glaucoma. The chairperson for this session is Dr. Thomas George, who is from Chaitanya Eye Hospital, Trivandrum. And we have Dr. Radha Ramanan sir in the panel, who is from iVision Eye Care Center, Chalakudi. Dr. Ranjani ma'am from Calicut Medical College, and Dr. Nabeed from Al Salama Hospital, Kannur. And I would like to introduce the speakers for this session. We have Dr. Sunita Dubey. Madam is a medical director and director of glaucoma services, Dr. Shroff's Charity Eye Hospital, New Delhi. She did her fellowship in glaucoma at Wills Eye Hospital, Philadelphia. She has special interest in GDDs and MIGS, and she is the first surgeon to start mixed procedure in India. She has received several prestigious awards. We welcome you, ma'am. The second speaker is Dr. Kirti Singh, who is Director Professor Glaucoma Services at Guru Nanak Eye Center, Maulana Azad Medical College. Madam did her post-graduation from Rajendra Prasad Center, AIIMS, Delhi. And she has won various awards and scholarships. And she has 18 chapters in various books, 55 peer-reviewed publications, and more than 350 lectures in various national and international platforms. And we have Dr. Abhilash Nair, who is from Senior Consultant, Cataract and Glaucoma Services at Giridhar Eye Institute. He has done his postgraduate from RIO Trivandrum and fellowship at Aravind Eye Hospital, Tirunelveli. I welcome all the speakers to this session, and I hand over the session to Dr. Thomas sir for chairing the session as well as moderating. Thank you.
Thank you, Shweta. As the previous sessions unfolded, we saw that time for discussion was running out because of time. For that same reason, let's launch straight into the session. I invite Dr. Sunita Dubey to come out with the MIGS talk. Dr. Sunita, you're on.
Yeah, sure. I'll share the screen.
Please do.
So at the outset, I would like to thank KSOS for giving me this opportunity. Can you see my screen? Yeah. Can you
Yes,
see?
and gone.
Okay.
It seems you're heard.
Yes. Okay. So I'll be talking on minimally invasive glaucoma surgeries. As we know, the surgical management of glaucoma has evolved over the last decade to include a number of conjunctival sparing procedures, and they are called minimally invasive glaucoma surgeries. And basically, they are designed to bridge the gap between the medical and laser therapy and more invasive filtering surgeries like tubes and traps. However, they can also be used after invasive surgeries. I'm going to show you some examples. And most of these procedures are often combined with cataract surgeries. So these are the procedures which we do in India. And these procedures target the site of maximum resistance and increase the flow through the conventional pathway, that is the trabecular meshwork. So we are all used to operate under coaxial illumination, but for the mixed procedure, the position and setup of microscope is very important. The microscope is tilted 30 degrees towards you, and the head of the patient is tilted 30-35 degrees away from you, so as to have the en-face view of the angle, as you can see in this picture. So it's very important to identify the angle structures with the help of this Swan-Jacob type of lens. You can use any lens, and you have to identify the all the structures, and then you do your procedure. So the advantage of these mixed procedures, especially with KDB, trabectome, and even bang, that it excises the trabecular meshwork completely as opposed to goniotomy. And therefore, these procedures minimizes the chance of scarring and reocclusion of the collector channels, as the remaining edges of the trabecular meshwork are quite far apart. So therefore, they're effective in adult patients across all severity of diseases, whereas goniotomy is not effective in adults. So first coming to trabectome, and which came to India 4 years back. It's a standalone device, and it's a plasma-mediated ablation system, and it ablates the TM and inner wall of Schlemm's canal. So advantage with this machine is that it incorporates irrigation and aspiration, and therefore it keeps the AC formed all the time and manages the blood reflux. So the procedure, you combine it with cataract surgery, and I prefer to do these procedures before cataract surgery when the eye is still firm and you can identify the trabecular meshwork very nicely. You insert the probe inside the eye and then engage the trabecular meshwork and start ablating it on one side, and then rotate it on the other side and start ablation on the other side. And as you keep rotating your gonio prism over the eye, you can target up to 140 degrees of the angle. So here this patient is a child with pediatric glaucoma, developmental glaucoma. And as you can see here, as you do your trabecular ablation, you can see this outer wall of Schlemm's canal. This is the white line, which is suggestive of outer wall of Schlemm's canal. And you see this membrane retracting while you're ablating the EM. So since these are minimally invasive glaucoma procedures, they can be done bilaterally, and I have done several patients like that. And this is a child, 14-year-old. He had a history of viral chorioretinitis, for which he was given PST, triamcinolone in both eyes, and his pressures were intractably high. So I was wondering what procedures to do. He was on maximal medical therapy, and I did trabectome in his eyes, both his eyes, and the pressure was very well controlled. And the reason being that he was steroid induced, and it was not a long-standing glaucoma. So the collector channels were still patent, and you can see beautiful clefts in both his eyes. Another procedure is KDB or Kahook dual blade. And again, this is specially designed for the minimally invasive procedure. As you can see, this pierces the trabecular meshwork, and then the ramp lifts and stretches the TM. And these are the dual blades which create parallel incision and excises a strip of trabecular meshwork. So it has a heel, as you can see, it nicely settles within the canal. And so there is no collateral damage here. So the procedure is more or less same as for trabectome. This is the blade, which is 90 microns. And so you are here, you're not ablating, you're removing a strip. So you see the strip of the TM, which is coming off. This is another patient. So this trabecular meshwork strip, you can see nicely coming off, which you can remove with the help of microforceps. And then you perform your cataract surgery. So this is a patient with Sturge-Weber syndrome, a child with angle dysgenesis. So I did this KDB goniectomy, and just want to show this microforceps. You just pull off the trabecular strip. So these procedures can also be performed after incisional surgery. So this is again a young female who operated for retinal surgery, vitrectomy and silicone oil injection was done. The IOP was intractably high. And so I decided to do tube implant in her. So she did well with tube implant, although there were 3 medications she was using after tube implant. And the tube was in place as seen here. After 6 months, she also developed this cataract because of the silicone oil. And the IOP was also not so very well controlled after 6 months. And so I decided to do phaco plus IOL with KDB in her because her angles were still open nasally. And right now also she is on some drops, although her systemic medications were taken off after this procedure. And you can see the cleft on the nasal side. Another patient who underwent multiple surgeries, again a steroid-induced glaucoma. She had failed phaco traps and even AGV implants. And he was on multiple medications, Diamox, glycerol, and 5 medications. So when I looked at the angle, there was no scope of performing any other procedure because the conjunctiva was scarred all over. And his angle was open. So the KDB was performed. So right now he is on maximal topical medications and off systemic medications. So if you can keep the patient off systemic medications, that is again a very big boon for the patient. This is a patient whom I recently operated, the traumatic glaucoma, with traumatic cataract, and there was some zonular dialysis here and the pressures were very, very high. And so I thought that I would treat the angle. The angle was open and you can see it can be easily done. And here then the cataract removal, and after taking out the cortex, he was a young boy, there was no nucleus, there was a central rent also here, which was managed with vitrectomy, and then the lens was put in sulcus. So right now the patient is doing well. Now coming to another popular procedure, GAT, and this procedure was described by Dr. Grover et al. And suture GAT is getting very popular in India as it is very cost effective. So here you make a temporal, a side port incision, inject some Helon GV, and then make a temporal incision, and then make a 2 millimeter goniotomy with MVR blade, and this unroofs the Schlem's canal. And then insert this mushroom-tipped Prolene suture into the Schlem's canal. And with the help of microforceps, the suture is advanced in counterclockwise direction along the circumference of the Schlem's canal. And most of the time it goes very easily. And if you don't find any resistance, that means it is in the Schlem's canal. You just pull the other end and then suture is pulled externally and withdrawn from the section. from the side port incision. So you can also use a bang technique wherein you bend this 25 gauge needle. So this can also be used, and it's very, very cost effective. And more or less, you're able to do a goniectomy with this, or use the needle technique. So lastly, the eye stent, again, which is commonly used now in India, and it is the pairing coated device, the smallest device. This is first generation device, and this is the one which we are using now more frequently, eye stent inject, and it comes with a preloaded injector. And in this injector, there are 2 eye stent injects. So here I performed the cataract surgery first, and after performing cataract surgery, you have to identify the angle, and it's very important to have an en face view of the angle, because you have to be looking straight into the trabecular meshwork, and then place this trocar to this anterior portion of the TM and keep it perpendicular to TM, and then gently dimple it, and then push the trigger button to implant the stent. And this reflux of blood is a good sign. That means that the collector channels are patent, and then just move 2 to 3 clock hours away and implant another stent. Once you have done that, just wash off the blood. And then just visualize the eye stents. So this was our paper, which was published last year. So the results of 58 eyes who were treated with trabectome, and the baseline IOP decreased from 23.4 to 14.1 at 1 year follow-up, and AGMs reduced from 2.4 to 1.6 at the end of 1 year. So irrigating goniectomy with trabectome has good efficacy and safety in both pediatric and adult cases in terms of IOP control and reduction in AGMs, and low incidence of complications. So these procedures, basically, you don't aim to completely reduce the number of medications, but the number of medications definitely are reduced, and the IOP is also well controlled. So now we have wide range of surgical options with these new techniques, surgical techniques. So if you judiciously select your cases, the glaucoma can be treated in a more patient-friendly way with low risk fashion, and it can be combined. Most of these are combined with cataract surgery. So even if the patient has mild to moderate glaucoma, if the patient is on 1 or 2 medications, you can, and if the patient needs cataract surgery, you can combine these procedures, and therapy of glaucoma can be tailored in an individualized manner. Thank you very much for your kind attention.
Thank you, Dr. Sunita. That was a very good overview of the procedures that we can perform in India. And we'll take the discussion at the end. And next, I'd like to ask Kirti ma'am to tell us about what to do with the trabeculectomy blood. It's always a problem sometimes.
Am I audible, and is my screen visible?
Yes, Kirti, both are audible and visible.
Okay, so thank you first of all, KSOS, for having me. And although we all wish that we don't have a bleb, including the patients, we still are forced to have a bleb because trabeculectomy is still the commonest surgery till we have affordable eye stents or the other mixed procedures. So let me talk about how to ensure a bleb's longevity, because once a bleb starts failing, then the second bleb and the third bleb, the rate is higher. So the main principle why blebs do fail is that glaucoma surgery success is dependent on incomplete healing. It's basically against nature, because it has to allow an aqueous outflow by the scleral flap into the subconjunctival space. You have to have a complete healing of the conch, but an incomplete healing of the sclera. And that's the genesis of the problems. And for those of you who remember the famous Laurel and Hardy, The problems we have with the blebs are either the Laurel type, where we have a shallow AC with a low IOP because of bleb leak, or a poor bleb because of the choroidal attachment, or it's an overfiltering bleb. The high IOP deep AC is invariably with tight sutures, and here the bleb would be poor. So to circumvent this problem of immediate problems of a shallow AC, low IOP, choroidal attachments, and all those is to have releasable sutures. Now, most of us do use releasable sutures. Initial phases, less of us were using releasable sutures. The techniques may be maybe many techniques are available. The one which we use is Cohen-Osher modified, and also I used to do a Richard Wilson technique. So here, as is evident, the suturing is taken from the sclera, and then the corneal bite is taken, and the loop is created on the triangular flap. You can have it whichever type of flap you want, and this loop is tied with 4 knots, the 4 slip knots, and at the end, post-op, within the first 2 or maximum 3 weeks, you will pull out this and the suture will be released. This step of titration while doing the suturing is very important because it tells you exactly how tight your scleral sutures need to be. So this titration step is something which you must keep doing multiple times, and that side port creation for titration while scleral suturing and the suture while conjunctival suturing is important. So do the bleb burping at the end of surgery to understand how much is the bleb leaky. Now we all want a controlled egress of aqueous, yet not a free flow. You want to prevent hypotony, and therefore that is why these releasable sutures have been used. This is the technique which we were using previously, the Wilson technique, and this conjunctival frill technique is the conjunctival suturing technique which we have adopted, all of us in our center. And this releasable suture is released very easily on the slit lamp. It has to be done within 2 weeks. It can be maximum left till 3 weeks when you're using mitomycin C, but you can do it before that whenever the IOP is high or bleb height is less. I go more by the bleb height and the IOP because in the initial first 2 weeks, the IOP is invariably low. So that will not give so much of a clue as the bleb height does. The second problem is the conjunctiva. We always have the princess and the pea story, which is who's the princess who can't tolerate anything is the conjunctiva. And this conjunctiva requires a total tender loving care with non-tooth forceps, use blunt dissection to hold the conjunctiva, use the MMC technique of the SAFE technique. What we are seeing over the years, I want this panel to talk about it. After PG analogs have come in, we are seeing a more sicker conjunctiva. We are seeing more subclinical inflammation. So what we do is we try to stop the AGMs, especially the prostaglandins 2 weeks prior. We switch on to Dimox and we add Lotipred, Lotisol, TDS for a week before the trap. And this is the conjunctival frill technique suturing we do now, because this prevents the bleb leak and the conjunctival anchoring is better, the patient comfort is better, and the surgical induced astigmatism due to the conjunctival anchoring sutures for a fornix-based incision is much less. In addition, the tear film disruption with the bleb is much less. So we have adopted to this conjunctival frill suturing technique, and the removal is equally easy. Again, on the slit lamp, you cut the one side of the knot and the other side is pulled out. The other problem is the leaking of the bleb. Either the conjunctiva is so loose to leak the bleb, or it is tight and you have this tightness. So suturing on the table, is it just right? I just hinted on that. How you do it is by the titration on the table. So that, I'm sorry. This, I'll have to just switch off the, yeah. So this is the bleb titration on table. As I said, we titrate for the releasable sutures and we titrate at the end of the conjunctival suturing, so that on table, you will understand that the bleb is totally watertight. And after you doing bleb titration, we have very less bleb leaks. So the bleb leak issue is taken care of by this titration. The next aspect I was asked to cover is the failing bleb. The previous ones were prevention of the bleb failure. Now, once the bleb starts failing, you can always do a bleb massage, and you should do a bleb massage. No time is too late for a bleb massage. Even after 1 or 2 years of surgery, you can still try bleb massage. It's not very often, but sometimes works. In the initial phase, it does work, and you can do frequent steroids. The other thing, as I said, was the releasable suture removal if the IOP is high or the bleb is failing. Again, bleb morphology is a better clue. Try to have 2 releasables and do a sequential release in 2 sittings at a gap of 5 days to 7 days. What are the signs of failing bleb? You can have a tenon cyst, you can have a walling off of the bleb, you have a reduction in the height of the bleb, you can have increased vascularity or corkscrewing of the bleb. IOP may or may not be raised in the early bleb failure. Gonioscopy is very important once you diagnose the bleb failure, because you want to see if the internal sclerostomy is blocked or is it external fibrosis. And once the internal sclerostomy is blocked, what we do is an internal revision where we do a ab internal procedure from the side port. You enter the anterior chamber under viscoelastic and you sweep out the iris, which is blocking the internal ostium, and hydrate the entry port and put pilocarpine. This is invariably followed with needling. You can do 5FU needling or MMC needling depending on the bleb microcysts or bleb ball. Why do we do an external needling along with it? Because once the sclerostomy has been blocked, the aqueous hasn't flown into the bleb. So the bleb has failed. So you would need to combine both the procedures to work together. So these were some of our patients with the blocked sclerostomy, which opens out after internal revision. In advanced glaucomas with macular split, how do you prevent bleb failure? Invariably, these patients have high IOP. There's increased risk for supracranial hemorrhage, hypotony, aqueous misdirection, ocular decompression, retinopathy, or snuff out. Precautions are you never put the patient in a high IOP, do mannitol or Dimox, try to lower the IOP, monitor the blood pressure. Another thing what we do is we do a paracentesis 30 minutes prior in the OR, do another case, and then come back to this case after 30 minutes and then do the trab. Basically, again, hypotony has to be avoided. So all the techniques I said before of releasable suture and titration have to be done. To avoid snuff out and decompression, if the patients who are predisposed to it, like Sturge-Weber or nanophthalmos, you do a pre-place suturing, that side port creation. I count till 10 when I do a side port creation and do a slow decompression, do the releasable suture and the bleb titration to ensure the conjunctival flap integrity. If the high IOP is not controlled despite maximal medical therapy, including acetazolamide and mannitol, we have tried diode laser cyclophotocoagulation in these eyes and wait for a month. The IOP invariably becomes less. You keep the maximal medical therapy on. Once the eyes are quieter, then you go ahead with the trabeculectomy. Combined surgery is not the topic, but still, whenever the lens vault is high, ACG patients or a patient who can't come back for a follow-up, do not hesitate to do a phacotrabeculectomy. Unlike the thought process that all phacotrabeculectomies go for failure, they do not. And in the setting of India, you do need combined surgery very often. The last thing is blebs may fail, do fail over time. That is nature's law, because we are playing against nature by asking sclera not to heal. So do a counseling, especially when these patients have minimal cataract, because trabeculectomy would increase the risk of cataract formation. So explain when you're doing a trab that this patient may require a second surgery of, when you're doing a trabeculectomy, that this patient may require a second surgery of cataract. Take the consent form for visual consolidation and not gain, and requirement for a lifetime of follow-up, because unlike cataract, glaucoma patients are your friends for life. And this is our step-by-step glaucoma surgery. And why I've shown this is a trabeculectomy journey is always full of twists and curves, unlike cataract. So when you do this surgery, you make the patient your friend for life.
Excellent talk, Dr. Kirti. I mean, it is not meant to scare people who are yet to start trabeculectomy, but that's how a glaucoma surgeon's life is.
Yeah.
Until you see the blood healthy at 3 months, we don't know if it's actually working or not. Now, we'll take the rest of the discussion towards the end. And Abhilash, can we have your talk on what is maximal medical therapy?
Yes, sir. I hope I am audible.
Yes, Abhilash, go on.
Am I audible? Yeah. Okay.
Audible, and let's take the scene.
Fine. Thank you. At the outset, I'd like to thank KSOS and the organizing team for having me here. Two wonderful surgical talks. Now we'll go on to medical therapy and what is medical therapy, what is maximum medical therapy. We'll just have a look. So this term, maximum medical therapy, is a rather old term. It evolved during the 1960s and 70s when the only options that the patient had, or rather we had, were pilocarpine, epinephrine, and systemic carbonic anhydrase inhibitors. So during that time, the problem of tolerability of medicines was rather big issue. We now have more tolerable medicines, and the definition of the maximum medical therapy has changed. And we'll see how it has evolved and what the options are now and how maximal therapy is evolving. Now, the simple explanation is a combination of all drugs that cause IOP lowering in an individual, which do not affect the quality of life. This is what probably we will like to define maximal medical therapy as. But for the patient, it is a point at which a person can no longer tolerate further medical therapy. So let's see how it is and why maximum medical therapy is not a great idea to practice. So these are the common medical classes of anti-glaucoma medications, the topical medications that are available in our country: the beta blockers, alpha agonists, carbonic anhydrase inhibitors, prostaglandin analogs, rho kinase inhibitors are now established. Cholinergic agonists were there initially itself, and beta blockers are available as FDCs with all these groups, and there are other combinations also available now. Alpha agonists with carbonic anhydrase and PG analogs with rho kinase inhibitors probably will be available soon. So now, why can't we give all these groups together? Maybe at least 5 of them. So we'll see why it is not a great idea. The main problem is with the side effects and the contraindications that are attributed to the medicines, each class of medicines. So we'll just go with all these in detail. So these are the group of medicines and their ocular as well as systemic side effects. So we know most of them. Most of it has got to do with stinging and redness, which are there in almost all the groups. And besides that, there are significant systemic side effects which we may not actually inquire, or the patient may not attribute it to the drops that they are using. They probably feel that it is due to some other issue, especially feelings like fatigue, depression. All these are there in beta blockers. Fatigue is there in alpha agonists. It's there with the carbonic anhydrase inhibitors. So when you use all these medicines together, the problem becomes manifold, and patients, they don't understand why they are so fatigued at the end of the day, why they don't have energy. There are contraindications to many drugs, especially the beta blockers, where asthmatic patients, COPD patients, patients with ischemic heart disease, heart problems, where you probably won't give beta blockers. Alpha agonists, again, contraindications contraindicated in very young individuals, those on MAO inhibitors and Parkinson's. Carbonic anhydrase inhibitors cause bitter taste, headache, again, feeling of tiredness, rashes, contraindicated maybe in sulfonamide allergy, but probably more for systemic use. Prostaglandin analogs, well, they cause severe prostaglandin associated periorbitopathy, which causes cosmetic problems for them. Rho kinase inhibitors, again, redness, hemorrhages, corneal deposits, eye pain. These are the associated side effects. Now, we'll come to something like the quality of life. Hello? Yeah. The quality of life, why it is a problem for glaucoma patients. One of this is impaired vision and impaired visual function. And this is probably due to the inability to do routine activities which the patient has been doing throughout his life. Patient may require assistance. Patient may bump into objects, physical trauma. They may even require a change of occupation because they no longer can have the visual capability to do the occupation that they are currently involved in. There's a lot of psychological trauma. Social withdrawal is present, psychological destabilization. All these are associated with glaucoma. Now, both of these have nothing much to do with maximum medical therapy, but coming to the usage of drops and their side effects. Now, this again causes an hindrance to active lifestyle because the patient may have to use one or two different drops. They may have to use it for many times a day. So that causes a stop in all the other activities. They have to probably lie down, keep their eye closed, do a punctal occlusion. So all these cause a hindrance to the lifestyle of the individual. Then there is an issue of local side effects which cause cosmetic problems. The friends of these patients may be saying that their eyes are always appearing red. There may be periocular pigmentation, sinking of the eye when we use prostaglandins for a long time. All these patients who are on bimetapros, we already know that they are on bimetapros when they walk into the room. That's how their face looks like. So these cause significant problems to the patient. Then there is a problem of systemic side effects like drowsiness, lethargy. Patient may, if they are drivers, they may find it difficult. They are working on heavy machinery. They may find the drowsiness bothersome. They may have to change their occupation. All these difficulties are associated with the use of multiple medications. So how can you improve the quality of life index for a glaucoma patient? Counseling is a very important thing. Like probably we don't get the time to talk to patients. We don't get time to listen to patients. And you always need to motivate these patients, encourage them when they are using their medications correctly, when their IOP is coming within control and within their target levels. You can always encourage them to continue medications. You can decrease or make the dosing schedule more appropriate. Like if the person is having a job that requires them to stay awake at night, maybe you can put the combination drops in the morning. Maybe a PG analog with timolol in the morning is probably good enough rather than always telling them to put it at night time. Drugs with lesser side effects. Now we are using carbonic anhydrase inhibitors like dorzolamide, which has more stinging compared to brinzolamide. So you can probably switch to brinzolamide. And for people who are like, addicted to reading, their whole life revolves around reading activities. So you can probably give them low vision aids. Generic medications on fixed duct combinations are better because the effects of preservatives is much reduced. And always review their schedules. Like maybe you can schedule their visits maybe 3, 4, 6 months later on, so that if they are controlled, they need not come back all the time. Now, coming to the issue of non-responders, around 10% of population is non-responsive to any single class of medicine. So we have to find if the medicines that the patient is using, are they really responding to the medicines that you have given them? So you have to evaluate the efficacy of the medicine. So when you start medicines, you must show at least 15% reduction in the intraocular pressure. That is not there. So if you start like latanoprost and the person is not showing much of a reduction, probably the person is not responding to that medicine, and probably you need to shift. So starting a medicine, and if you don't see a response, there is no point in continuing that medicine. Always shift. And always find out if the person is having the same systemic medication that you are giving. So if they are already on systemic beta blockers and you are giving beta blocker, probably that beta blocker you are giving as a topical medication won't have that same effect. Coming to the law of diminishing returns. Now, we know that prostaglandin analogs give around 30%, 35% reduction in the IOP, beta blockers around 25, and the remaining are probably a bit less compared to these two. Now, when you add medicines, you will get some sort of an additive effect. But as you keep increasing the number of drops, the reduction in IOP that you get will be much less than what is actually written in this chart. So the more number of medicines you add, the less amount of reduction in IOP you will get. So adding a fourth medicine probably will give you maybe a 10% reduction, and a fifth medicine is not going to really help much. Now, coming to the financial burden, this is a very important problem with glaucoma patients because they use drugs for a lifetime. And the cost of these drugs are not really coming down, not helping. The problem with loss of wages because they have to take leave, they have to travel, probably even if they are undergoing surgery, stay. The accompanying person also has loss of wages. They also have to pay for their conveyance. There is lack of insurance in most of our patients. 90% of our patients, unless they work in some central government institution, they don't get any medical reimbursement for the glaucoma medications. Most of these, information that I have collected from this article in the Indian Journal of Ophthalmology, which was 10 years old, but still it is very much relevant today also. So this shows the financial burden. Like a person in a lower income group, he spends around 40% of his monthly earning on glaucoma. So not just the drug, but also the tests that he has to do, the traveling that he has to do. And most of them they stay away in the rural areas, so they have to come a long way. They probably have to spend one night at the near the hospital and then go back. In the higher income group, probably it is not that much, but still we have to take care of the lower income group, middle income group also. So most of our patients will belong to that category. So as you increase the number of drops, the financial burden increases because the cost of the drops increases. So coming to the question of adding medications, you find that your patient is not achieving the target with the medications that you have initially prescribed. Now, before you add, always stop and think. Is the patient compliant with the dosing schedule? Is the person using the medicine as you have advised? Are they using it every day? Are they following the strict method of installation? Are they doing the punctal occlusion? Do they just lean back and just put it while they're sitting and watching TV and just go ahead and watch without any, lying down or closing their eye? Is the proper installation being done? Are there any systemic conditions that are causing the glaucoma to worsen? We have Dr. John himself mentioned a lot of systemic conditions that may be present, which cause worsening of glaucoma. Dr. Manoj also touched upon them. So are there systemic conditions? Is the person using steroids and in any form, like they don't know, even you don't know, then that may be worsening the glaucoma. Is the person having sleep apnea? So all these things you have to find out, you have to inquire. And of course, financial capability of adding another medicines, whether they'll be able to support the increased cost. Now, when you do add, if you have to add and you do add, always add a medicine with a different mode of action. Like if you have started on prostaglandin analog, you can add a medicine that decreases aqueous production, probably a beta blocker. And then third medicine, probably better to add a medicine with another mode of action, probably a Rho kinase inhibitor, which increases the trabecular outflow. So 3 different modes of action probably will give you a better IOP reduction than the same mode of action. Fixed drug combinations are good because one, it is financially more prudent. You will get a lesser cost in a single bottle. rather than using two different bottles. And of course, the issue of preservatives is also reduced. You can also give a simple schedule, maybe maximum of 2 times a day. So the person can just, 12-hour interval, they can break their schedule and put the drop for 5 minutes. They have to rest and then continue on. And always use BKC free or preservative free medicines as they're available now. Coming to the issue of preservatives, now preservatives are, they are the main culprits that cause ocular discomfort. Some of them cause subconjunctival fibrosis, epithelial apoptosis, conjunctival squamous metaplasia, meibomian gland dysfunction, all sorts of issues. And BAK is the one that is the biggest culprit. So there are newer preservatives like SOC, berberate, and all, probably more friendly to the conjunctiva. But preservative-free medicines are the way to go, and unims are the best options because you just use them for 1 day and you throw that back. So throw that away. So more costly when you consider long-term treatment. So what they have developed is new technology, better bottles, which prevent backflow of air into the depot, so that doesn't get contaminated. Lots of complicated machinery, but these are getting more and more, commonplace and can be used. They are truly preservative-free. Now, what are the possibilities? Like, if you want to, even with all this things don't work, you can always go in for laser procedures. Laser procedures like trabeculoplasty probably give you a 20 to 25% decrease in intraocular pressure. So maybe you can reduce 1 drop with this procedure. And of course, if nothing works, then surgical way is the only option left. So coming to a few guidelines, the minimum number of bottles that you prescribe, the more compliance, the more the patient is going to be happy, and probably you will find lesser intraocular pressure in persons who are using lesser number of bottles. Preservative free to preserve the conjunctiva for further surgeries which might be required. For younger patients, probably it's better to think about surgery earlier compared to an older individual, because they are probably going to have a longer lifetime and the conjunctiva is going to become worse as you use more and more medications. And even studies that were mentioned earlier today, Dr. Kamala mentioned CIGHTA study, which mentioned that if you have a moderate or severe glaucoma, it's probably better to do a trap earlier on rather than stay with medications. So maximal medical therapy, I'd say ideally 3 drugs, maximum of 4, but that also, if possible, better lean towards surgery rather than persist with drops and more drops. These are my references. Thank you.
Thank you, Abhilash. You have really defined maximum medical therapy. Unlike what most people would think, it's not the maximum that you can give. It is a maximum that the patient can afford to use economically, side effect profile-wise, systemically, and the minimum that is required for that patient to get the IOP control. We go on to try to discuss a few of the topics. And one thing that anybody new to MIGS would want to know is, which is the easiest technique for a person to try to learn first? Sunita, can you give us a
sure.
update? Because you do all of them. I do only GAT, basically.
Okay, you do only GAT. So GAT, I would say, is the easiest to start with. I think the easiest to start with is BANG. And I think the easiest thing to do is first to learn intraoperative gonioscopy.
Absolutely.
After doing cataract surgery, what you can do is change the position of the microscope and tilt the head of the patient and just try to visualize the angle. So under high magnification, and try to have an en-face view wherein you are looking directly at the angle and the trabecular meshwork and not looking down at the angle. Because most of the procedures, especially eye stent and even GAT, you have to, cannulate with the proline suture. So you have to have a very clear view of the trabecular meshwork. So you have to do that. So first master intraoperative gonioscopy. And then I would say that you can start with bang. So because it's very cost effective and you just have to bend the 25 gauge needle and just try to first feel the angle with the second instrument, which you use for in phaco, or maybe with the iris hook, and then just try to get a feel of trabecular meshwork and then just try to take a little bit of angle with bang. So I think bang is very easy. And then I would say once you learn bang, then maybe I think KDB is more or less same. Although KDB is more standardized and it is very well designed. It has a heel which sits into the Schlemm's canal. So you are not damaging the, the surrounding structures. So I would say start with bang after mastering the intraoperative gonioscope.
Sunita, I mean, putting cost aside, I would have thought iStent would be the easiest to do, and then would be KDB. Because iStent is in and out.
No, I
you just have
think
to identify
that's
the
in
trap.
and out, but for that you have to really have a hang of the angle because it's a very expensive device. When you start doing
That's what I said.
No.
Cost
So you
away.
are under mental pressure, whatever, I feel that it should go right into the work. So I think that kind of stress and pressure is there when you start using iStent. So yeah, I think that is also there. But what I feel is that you start with the procedure which is under your control. That is what I mean to say for the beginners. And once you have the hang of, you can start with the other procedures. Yes.
RR sir, Radharam sir, anything you want to add on to this?
This subject, I think I don't have much personal experience on this thing, but this is one surgery. Sunita, you have said that most of the cases you are combining with cataract surgery. Or
yes.
So that is the best thing to start with actually, because you are not subjecting the patient for another procedure. I think your suggestion is very good because we have to reduce our learning period. So we have to start doing gonio procedures during our routine surgery. So that is well taken. Thank you for your that suggestion.
Yeah, and in the chat, I think people are writing that it is not easy to get into the angle, and sometimes it may not just fit into the trabecular meshwork, that iStent. So you have to really be confident, before starting iStent. So.
And it's not a joke. You slip a little bit, you get a cyclodialysis. Or the other side, you get a Desmet stripped. You start a DSEC or DMEC or whatever.
Yes.
So intro of gonio first. After that, only think about anything else.
Yeah.
Next, we go on to Dr. Kirti. Your talk. You emphasize the releasables a lot. I agree with you. But if you've got a good access to suture lysis lens, which is very good, and a good suture lysis laser, would it be the same as just putting a regular suture? And then cutting time?
Yeah, initially we used to do that suture lysis on the argon laser, but the patient is very uncomfortable, and very often in Indian eyes, we have a thicker sclera, we have thicker iris and the pigmented, and the bleb is sometimes vascularized, the visibility is poor. So both the discomfort, the visibility makes laser suture lysis a little down for me. And I've started doing releasable sutures, and so do all my residents, and we've never looked back since then. And I think it's just the initial 4-5 cases where you have that learning curve. Otherwise, releasable sutures are actually a dream to do.
Can I add to it?
Yeah, sure.
Yeah, sure. No, I think you're absolutely right, Dr. Kirti. Releasable, with releasable sutures, we have the liberty to release the suture within first week.
Yeah.
However, with laser sutural lysis, if the bleb is edematous, which often it is
vascularized, edematous.
Vascularized, if it's little elevated, if there's a hemorrhage, then you won't be able to do laser sutural lysis. So releasable sutures, I think I also go in favor of releasable sutures. Later on, If you have 1 or 2 fixed sutures also, then you can do laser suturolysis later. But it cannot be done within 15 days of
it has to be done initially. And once the laser suturolysis is done, invariably you're doing it because of tight suturing or a failing bleb. That's the reason.
Yeah.
And sometimes you have that bleed there, and the bleed itself is going to be pro-fibrotic. You're going to it's just do the same thing which you don't want to do.
I've had hypotonia with both situations, suturolysis and releasables. And I've had patients who probably rubbed their eye and converted this releasable into an adjustable situation, because the same knot can be used. And earlier they used to use a Hoskins forceps and wriggle it about, and it loosens. So I've had releasable sort of loosening on me without me trying to release and giving me hypotonia.
No, actually, both Wilson's and Cohen-Osher technique. The Cohen-Osher technique, if the patient rubs, you can have it. But touch wood, I've not had that, which doesn't make it that we can't have it tomorrow. The releasable sutures, what happens is the patients, my problem is a different one. They would forget to come back to you, and they would come back to you after 3-4 months, and then the suture is very deeply buried. So that's one problem which you have to counsel the patient, that this suture, you have to come back and get it released, because rather than rubbing it and taking it out, they're the ones who would never come back and get it out, So the both sides of the story are there.
Dr. Nabeed, do you want to add anything to this discussion?
No, sir, actually.
Gauri is suggesting retentive viscoelastic. Gauri, can you come in with that? Healer flow used to be talked about in conferences. We didn't have it. What do we have in India?
The question was about the iStent or for the Bang or KDB, which viscoelastic if Helon GV is not available.
You are answering a question off the YouTube, I suppose.
Yeah, Hylene
Okay.
Z+. So that is also available. That's made by Zeiss. So that can also be used. That's what I did. I replied to a question.
And Care Group also has Helon 6. That is a very good and very cheap option, reasonable option.
Yeah.
Care Group. Helon GV from Care Group.
Okay. Is Dr. Rajni around? No. Dr. Radharamnan, how late would you go for a bleb revision or needling to retrieve a bleb?
This is a tricky question.
You can't do it before 3 weeks. How late can you think about it?
Before coming to that, actually, I releases the sutures much earlier than what you suggested. Actually, now releasing sutures are my surgery. It is only one suture now. I think everyone is adjusting or refining the procedures according to their results. So it won't work. Someone is doing some procedure, won't work similar in other cases. So coming to your question of, I have done it after even 2 years, 3 years. But I will tell you, the results will be different, because depends upon that particular patient's situation, and explaining to him, I'll be taking up that cases. But definitely there are some cases beautifully worked and is still working very well. But the results will come down. But now with the mitomycin and FIFU and all is better working.
Can I answer that question, Dr. Thomas?
Yeah, please do.
Okay, so we had just, in fact, this paper won the best physical poster award, poster podium award in the AIOS, where we had did a study on the needling for the bleb failure. Would you believe me if I told you I have done a needling for an 11-year-old bleb and it has revived? I've done a needling for a Sturge-Weber patient who failed after 3 years, a lady, it revived. No, all the cases do not revive. Even in the paper by Dr. Vanita, she has 60 to 70% success rate. We have around a 50% success rate. But I would say needling is worth a try anytime, because it is a pretty low invasive procedure. 1 needling, 2 needling, 3 needlings. If 3 needlings fail, then you go for a bleb revision, which means a repeat bleb surgery. Because having said that, once your bleb is failing, mostly it is subconj fibrosis. And once that tendency is there, a repeat surgery also is likely to fail. So needling is definitely worth a try. 1, 2, 3, and as high 11 years in my personal experience. I think that's the, but obviously I don't have a long-term follow-up of that patient. I had a 3 months follow-up. It survived.
Ma'am, I couldn't agree more with you because 3 years back, I needled both eyes of very advanced glaucoma, 80-plus-year-old patient who had a TRAB in 94 and 95.
Okay.
That's not 11, it's nearly 20 years down the line. It still works. I would go for that rather than sacrifice one more area of conjunctiva, which I may need for another TRAB or AGV or whatever.
Correct.
And years down the line, he's already a macular split, and you don't want to do anything very drastic if you can help it.
Absolutely. And one more thing, that diode laser cyclophotocoagulation, everybody feels, it doesn't work. It does work. You can do it in advanced glaucomas. If your TRAB is failing, it is definitely 1 needling and 1 DLCP is worth a try again.
Could I ask something regarding this needling?
Yes,
has
please.
anybody tried ab interno needling rather than ab externo?
I have. I just showed that internal revision video if you saw.
Yeah.
I go when I find that the bleb is totally flat and I have done a needling and it's failed. The external needle and the sclerostomy is open. In that situation, I go from ab interno. And I have some instrument called as a straight rod. It's a very simple instrument, a titanium or a simple straight rod, because I'm little wary of using a needle. I just go from the side port and go beneath the flap and then try to come out in the subconjunctival space. Basically, you're going to go between the superficial and the deep flap and try to come out. I've done it more than 7-8 cases like this. Couple of them had pretty bad hypotony in the first 2 weeks, which recovered, because such patients invariably have a cyclodialysis along with it when you are doing this type of a procedure. But otherwise, it does work. But I would not do it in the first sitting. I would do a needling the conventional valve first time. And only if it didn't work, and I really found on an ASOCT that the bleb is totally flat, and I can see the scleral flap suture adhesions, then I would do it. Having said that, I forgot to mention that in the precautions, now I'm shifted to using mitomycin C between the scleral flaps for 20 seconds. We use mitomycin C just subconjunctivally, but now I start using, in addition to subconjunctival, once I do the scleral flap dissection, I go back to the Miracles or the collagen spear and soak it and then rub it between the superficial and the deep flap for 20 seconds so that this flap adhesion is less.
Okay.
Ablash, I would prefer to call it internal revision rather than needling, because we don't use a needle to go in. I actually use a cyclodal spatula. Only difference here is I've got a couple of lenses that have been given to me for which I've distributed the Zen Gelsen. So those I use on the table and make sure I get into the right place. Then you don't have a cyclodialysis.
Okay.
And of course, it has to be supplemented with subconjunctival mitomycin.
Yeah, that's what I said. Moment you have a bleb failure from whichever side, the subconj tissue is gone. So you have to revive that. Which lenses do you use, Dr. Thomas?
It's basically like our regular Goldman, but then it is hand-me-down from NHS, one of my friends, Zen Gelsen's package lenses.
Okay.
I mean, like all the iStent lenses and things like that, you can keep re-sterilizing and using in India. Otherwise, it doesn't make sense economically. Abhilash, the new kid on the block for redness, I think, is our ROCK inhibitors rather than the PG analogs anymore. What's your opinion on that?
My experience with ROCK kinase inhibitors much less compared to PG analog. So I think for everybody, that's holds true because that's been there for more than 20 years. So I'd rather start PG analogs rather than going for rho kinase inhibitors, especially if you're starting it as a first line medicine.
I'm talking about tolerability.
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 Okay.
I think ROCK inhibitors give us a lot more hyperemia in about 2-3 months' time. That it is significant dry eye symptoms is what I see.
Yes.
I mean, it's my opinion. I have not analyzed my cases.
Yes, Thomas.
We have, can I answer this question? We have analyzed, we give, because ours is a tertiary care institute. So we are getting a lot of patients who are very advanced and even secondary glaucomas, and you need to use a 4th or a 5th drop. So what we have seen is that nitarsudil is causing much more hyperemia than ripasudil. And the other thing which we are noting in secondary glaucoma is reticular corneal edema. So apart from hyperemia, reticular corneal edema is also very common, especially in secondary glaucomas. When you are using it as a 3rd or 4th or 5th choice, so a lot of reticular corneal edema is there. So, but it is reversible. Once you stop the drop, the reticular corneal edema also is okay within a few days or weeks. So that, yes, they are associated with a lot of side effects. I agree with you.
That is correct, madam. Actually, last week, one of my post-op cases, it was operated elsewhere. This patient came with a lot of edema, reticular edema. And I think a few patients came and told me, so you can even stop my medicine, but I cannot tolerate this because that much of problem patients are facing with some of the drops.
I think once you go past 3 drugs, we should start motivating the patient for surgery rather than add your 4th and 5th and then 2 years down the line deal with a very scarred conjunctiva.
If I could just add one thing, you know what we are finding, we just recently finished the study of the cytopathological markers in trabeculectomy surgeries. We compared them with cataract eyes. We did a biopsy of the conjunctiva pre-trab and pre-cataract. What we found is a significant loss of goblet cells in the trab patients, and an inflammatory markers also were deranged vis-a-vis cataract patients. So what we are seeing is subclinical inflammation is much more, and especially after PG has come in, PG has caused more inflammation. So I would say the maximal medical therapy, you don't wait also for too long, because then the trab failure becomes higher. So it's a balancing game always, but subclinical inflammation may be more. There's no hyperemia, the eye is quiet, but that conjunctiva is becoming sicker and sicker.
So we prime the conjunctiva by giving steroids.
We also do that. But,
before, if the patient is on multiple medications.
Yeah, for a week. How long do you give it? For a week or more?
For a week before surgery.
That's what I said. Lotusol, we are doing it for a week now. That doesn't take care of the goblet cells, no, Sunita? They will never come back. It just takes care of the the lymphocytes somewhere.
But at least some inflammation is reduced. So steroids, I think, should be given before glaucoma surgery, if the patient is on anti-glaucoma medications.
No, we are also doing that. In fact, we are giving very often Dimox. We're giving IOPAR for a week, and if they can tolerate it,
it's good to stop the medication.
Stop the AGMs and start IOPAR SR and then call them for surgery. Yeah.
But none of these will help us with very bad orbitopathy. I've had patients who have been on PG analogs for a decade plus, and the lids are so board-like that the speculum has difficulty going under. Have you guys seen those? RR sir, what's your experience?
Yes, definitely. Actually, I was thinking previously we used to operate because older people like us, we used to operate after Timolol. We used to operate. That time the results were much better.
Much better. I entirely agree with you. Entirely agree with you.
We never used mitomycin that time.
Yes.
The results were so good. Now we are using a lot of medicines, and we have a lot of problems with the lid, the conjunctiva, everything. Whatever we are doing, it's stopping and all. It's not, to some extent, some work, but it's really horrible.
Entirely agree with Dr. Raman. We used to have the trabs, which was to be so nice, and 10 years follow-up, 15, they're still doing well. And the recent ones, because they're on multiple meds, It is a problem. 100% agree with you.
That is true. When we were doing PG, we had great discussions about whether mitomycin should be used or not. Now there's no question. Everybody gets mito. In my situation, at least.
You can use amniotic membrane. We've been using amnion. If older patients and especially pregnant patients, which are a couple of them, but I'm using amnion very frequently, with or without mito. Yeah.
Okay, Abhilash, anything else you had? We need to wind up. We are past our time. Actually, we need to hand over to Sweta.
Nothing much, sir. I think we call it a day.
Nabid, anything you want to add to the discussion?
Now we have seen during laser suture lysis, after laser suture lysis, we have seen congenital pitting also. Actually, there is micro holes actually.
Burns. That's if you use. I mean, if you can't see too clearly, or if you got pigment in the conjunctiva and you still persist with it, you can burn a hole through it.
Yes.
That's what I mean. It looks like a pit, and sometimes it actually leaks.
Yes.
Is Ranjini madam around? I don't see her. No. Okay, Sweta, I think we are through. We are through with time also. Sweta, please take over and conclude the session. Thank you all. It was great seeing Dr. Sunita and Dr. Kirti from long distance. See you in Pune next. Abhilash, I'm not belittling you. You're nearby.
Thank you, sir. Thank you.
Thank you.
Thanks a lot for a great
It was a very lively discussion. Thank you.
Very good.
Even Kochi also.
Thank you. Thank you all the speakers and panelists as well as chairperson. It was a really wonderful discussion that we had today. So all the 3 sessions, I hope we have covered. All the speakers have, even though I've given a very limited time for everyone, they have managed to cover the topics in a very beautiful manner and an informative manner. I think this was a fruitful discussion in all the sessions. And I thank on behalf of Kannur Society of Ophthalmic Surgeons, Kerala Society of Ophthalmic Surgeons and Ophthalmic Society of Kannur, all the speakers, panelists, as well as the chairperson. Thank you for accepting our invitation and making this session a grand success. Thank you.
Thank you. Good night. Night.